This
Just take your
conference
time.
will now be
how
recorded.
can I screen? Hello,
Yeah,
ma'am. How can
yeah, yeah,
I
yeah.
sharing
I'm
screen?
just
It is not
one.
allowing me.
Yeah, now you can click on the screen button and you'll be able to share your screen with us.
Okay.
Yeah,
Is it visible? Screen visible, ma'am?
not yet. Just give me some time. Yeah, yeah, now it's visible.
Is visible? No. PowerPoint is
Yeah,
opening, ma'am.
it's visible. Yeah, it's opening.
Okay, ma'am. Thank you.
Yeah.
Is it visible, ma'am?
Yeah, now it's visible.
Can I start my presentation?
Yes, you can start with your presentation.
Okay. I am Professor Samapada Mandal from Gaurabanga University. Amid COVID-19 pandemic, we are doing everything from our home, and this is a webinar. I am taking part in this webinar, which is Addiction and Physiology webinar. First of all, I'm many thanks to the organizing committee and all members of the organizing committee member. My speech title is Can Probiotics be used in the treatment of neuropsychological disorder? At first, we have to know the probiotics, prebiotics, and symbiotics. The probiotics are live microorganisms, and prebiotics are substances that are utilized specifically by the probiotics to exert their biological effect. And collectively, the probiotics and prebiotics are known as symbiotics. And symbiotics are these are responsible for some secretion of components which are good for health, that means provide beneficial of health, and these are postbiotics such as lactic acid, bacteriocin, as well as short chain fatty acid. And probiotics are then called psychobiotics because psychobiotics are those probiotics which are responsible for the good mental health as well as neuropsychological disorder balancing or reduction. And psychobiotics characteristics and mechanism of action we have to study. And probiotics and psychobiotics stress, anxiety and depression, as well as some neurological disorder, Parkinson and Alzheimer's disease. Ma'am, hello, is this okay? Hello.
Yeah, that's good. That's good. Yeah, we are
Okay.
able to listen to your voice and your screen
Okay.
is
Okay.
visible.
Thank you. Yes. Uh, and so, what are probiotics? These are live microorganisms, mainly the lactic acid bacteria of the genus Lactobacillus and Bifidobacterium. Beside those bacteria, there are some Saccharomyces, that is fungus, as well as other bacteria such as Lactococcus, as well as bacillus and some other strains. And prebiotics are main examples are fructooligosaccharides as well as galactooligosaccharides. The main two components are utilized by the probiotic microorganisms Bifidobacterium and Lactobacillus in the gut, and they maintain the gut microbiota balance, reducing the number of pathogenic bacteria as well as the increasing of beneficial bacteria. And these combination we have already discussed. The probiotics and prebiotics are collectively known as symbiotics, and the psychobiotics are those that are responsible for the changes of mood or the some psychiatric disorder. Before going to start, the role of probiotics in psychiatric disease as well as neurological disorder, we have to know the properties of probiotics as well as the psychobiotics. Mainly, actually, the probiotics are psychobiotics, and the same microorganisms play a role in relation to psychiatric disorder as well as the neurological disorders. These must be sodium chloride tolerant. A high range of sodium chloride tolerance are seen in those microorganisms, and they are bile salt tolerant as well as low pH, that means acid tolerant, because they are residing inside the gut, that means large intestine. After consumption in live form, they remain live and they are resistant to sodium chloride, bile salt, low pH. And when they remain outside the body, they also showed resistance to different types of different types of stressors and as well as temperatures. And some probiotics may be safe because we have to test such microorganisms for non-hemolytic because we know that some pathogenic microorganisms can produce hemolysin and cause the hemolysis of RBC, destruction of RBC. But the lactobacilli, which are to be used as probiotics, cannot utilize such hemolysin or produce hemolysin, and they cannot destroy or breakdown of RBC in the body, and they cannot produce DNase as well as gelatinase, and they, does not possess some such microorganism does not possess antibiotic resistance, mainly the transferable antibiotic resistance, because we know that antibiotic resistance, if mediated in the plasmid, they may be transferred from the good bacteria, lactobacillus or bifidobacterium, to pathogenic bacteria. But if these are intrinsically resistant, that means resistance property are involved in the chromosome, they cannot be transferred. So these are the good characteristic features as well as the safety profile of probiotics, that means lactobacilli or bifidobacterium, intended to be used as probiotics. Here, antibiotic susceptibility test, we have tested the such bacteria, that means the L. fermentum, the species Lactobacillus fermentum, plantarum, and Lactobacillus species. These are all sensitive to the antibiotics which are used. As in both method, the agar dilution method, when we have determined the MIC as well as zone diameter wave inhibition. Here, zone diameter wave inhibition are represented the resistant to vancomycin, because we know the vancomycin is intrinsically resistant, and internally resistant gentamicin and amikacin. These are also intrinsically resistant, but the sensitive to antibiotics to which the organisms are found, that the amoxicillin, ampicillin, as well as tetracycline. So these antibiotics to which the strains showed sensitivity, and these are non-transferable. Mainly these are sensitive. And here we know such probiotics or psychobiotics must show antagonistic activity. That means they are capable of utilizing. Hello, ma'am. Hello. 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 Am
Yes,
I
sir.
audible?
Yeah.
Am I
Yeah, you're
audible?
audible.
Yeah.
Audible, audible.
Okay.
Yeah.
Okay. Antagonistic
Audible now.
activity. Okay, thank you, ma'am. Here we are showing that some species of Lactobacillus animalis, Lactobacillus plantarum, Lactobacillus acidophilus, and rhamnosus. These all are antagonistic to the pathogenic bacteria, Acinetobacter baumannii, Escherichia coli, P. vulgaris, as well as Salmonella typhi. These are the pathogenic bacteria causing different types of disease in human, and they show the large size of zone diameter around the. Here we have utilized the agar overlay method. These spots are the lactobacilli. There is a spot culture around which against the pathogenic bacteria, baumannii, Escherichia coli, P. vulgaris, and Salmonella typhi, they show inhibitory zone, that means zone diameter inhibition, and this is the table that are zone diameter inhibition found in this test are presented in here. So these are good probiotic lactobacilli showing antagonist activity against pathogenic bacteria. And another important characteristic feature is the proper identification. We have isolated from cult isolates, and these are strict repeatedly on the MRA sugar medium, and thereafter we perform the TSI, triple sugar iron test, and gram staining, oxidase, and catalase. The strains which are gram positive, rod, non-spore forming, oxidase negative, and catalase negative, these are the lactobacillus. And we have also performed another test, different types of biochemical tests, as well as carbohydrate utilization test and 16S RNA gene sequencing. These are the accession number, NCBI gene bank accession number deposited, and these are correctly and perfectly identified and used as local strain of probiotics and may be utilized as psychobiotics. And so we are seeing this the mechanism of action of probiotics or the psychobiotics widespread use that may be isolated from different types of locally available sources such as curd or other types of fermented food. They show colonization resistance, acid and short chain fatty acid production, regulation and intestinal and normalization of part of that means dysbiosis of microbiota in the intestine or gut is occurred, and these microorganisms lactobacilli probiotics are responsible for the balance of such dysbiosis and reduction of the pathogenic bacteria. That means competitive exclusion of pathogenic bacteria by these probiotics are happened, and increased turnover of enterocytes. That means these probiotics are also responsible for the employment of some new enterocytes in replacing of old. That means if loss of enterocytes occur, and here species level, we know some species are synthesizing vitamin, minerals, and direct antagonism that we have already discussed, and gut barrier enforcement, bile salt metabolism, enzymatic activity, and neutralization of carcinogens. Carcinogens are destroyed by such microorganisms by enzymatic activity, and production of specific bioactive substances such as bacteriocin, short chain fatty acids. Endocrinal effects are also visible, and we will discuss this effect, immunological effect and neurological effect. Here is the study is related to neurological, and these are strain specific. And one interesting feature is the production of bacteriocin. We have isolated lactobacillus fermentum from cod, and we have isolated the bacteriocin from this fermentum. And the size of that means the molecular size of bacteriocin isolated was 13.1 kDa, and this is very uh, excellent for the inhibition of growth of pathogenic bacteria. These are the whole well in which we put the bacteriocin and culture on a culture plate. Swabbing culture was done with pathogenic bacteria, and against pathogenic bacteria, this a zone of inhibition were obtained. And synbiotics, these are the combination of probiotics and prebiotics. Actually, the probiotics are live microorganisms and prebiotics are substrates, galacto-oligosaccharides or fructo-oligosaccharides that are specifically utilized by the probiotics. These are they may be synergistic and complementary. These the mechanism action of complementary are here. That means here probiotic and prebiotics are acting independently, and in synergistic action, the live microorganisms which are selectively applied, and the substrates as in the form of prebiotics are selected. These two material, the live microorganisms and substrate, that means prebiotics, are acting dependently, that means synergistically, that means in combination. So both probiotic and the live microorganisms, in both cases complementary and synergistic mechanism health benefits are achieved. And actually these prebiotics and the substrate which are selectively used by live microorganisms in synergistic action, both are acting against autochthonous microbiota and achieving the beneficial effect. Here are the summary of prebiotic, postbiotic, and complementary symbiotic, synergistic symbiotics. These are presented here. That means regarding safety, identity, and scientific validity, all are positive. That means all are required component for probiotic, prebiotic, and complementary synergistic symbiotic. And strain designation is also required except prebiotic, because these are substrate. There is no live microorganisms. Here microorganisms deposition in such a gene bank, NCBI gene bank. Deposition of some microorganisms is required. A mechanism of action must be done before utilization except probiotic, because these are already tested. And selectively utilization by resident or administered live microorganisms is required for prebiotic and complementary symbiotic. And in case of by co-administered, only synergistic symbiotic is required. And for health benefit, all are applicable for all criteria, and here also the proper condition to be used are required for all. And except probiotic and complementary symbiotics. Other two cases, selectively utilization of substrate is required. And here, gut-brain axis is maintained by such psychobiotics, that means probiotics. The pathway is the connection or a balance between the gut and brain is required, because dysbiosis may be happened here, that means in the gut, and after application of probiotic through vagus nerve, enteric nervous system, as well as hypothalamic pituitary adrenal axis is activated, and the communication is established. Here the mechanism of action, so we know the psychobiotics, that means prebiotics and probiotics, both are responsible for secreting different types of good hormones by the activation of the enteroendocrine cells, and also short chain fatty acids, SCFAs, and these are actually supplying to the brain, and to act against the pro-inflammatory cytokines, as well as bacterial lipopolysaccharide, as well as glucocorticoids, which is in these devices secreted by adrenal gland with the activation of hypothalamus as well as pituitary gland, because cortisol or corticoids are secreted, and here we are seeing that blood brain barrier is disturbed. But in case of probiotic application or psychobiotic application, peptide tyrosine, cholecystide kinin, and galactolipid peptide 1 is secreted, and anti-inflammatory substances are secreted, and these are transmitted through blood to the brain, and the blood brain barrier is maintained, that means disruption was balanced. And here also reduction of pathogenic infection is possible, as well as the reduction of pro-inflammatory cytokines are possible. But in dysbiosis, it was due to leaky or as well as inflammation. So this is the gut-brain axis, which was maintained by psychobiotics or probiotics. And some gut microbiota which are producer of some neurotransmitter are gamma-aminobutyric acid, serotonin, norepinephrine, dopamine, noradrenaline, acetylcholine, that are acting in this microbiota gut-brain barrier, and the microbiota such as Lactobacillus, Bifidobacterium, Bacillus Saccharomyces, as well as Escherichia coli and Lactobacillus are producing such kind of substances. And these are some psychiatric disorder, anxiety, depression, and stress. In case of anxiety, lactobacillus and bifidobacterium different strains are used. In case of depression, lactobacillus, lactococcus, bifidobacterium are utilized, and in case of stress, lactobacillus, bifidobacterium are utilized. And in psychobiotics, if multiple depression or in combination with one another of psychiatric disorder is seen, that means depression and stress, bifidobacterium longum, bifidobacterium long different strain, and lactobacillus fermentum. Here in depression and anxiety, lactobacillus hepaticus, lactobacillus rhamnosus, and in stress in combination with anxiety, bifidobacterium bifidum, different strains, Lactobacillus acidophilus, Lactobacillus brevis, and different strains of Lactobacillus acidophilus are utilized. Here some psychobiotics or probiotics, a large number bifidobacterium, streptococcus, lactobacillus, and lactococcus in combination are used, and here L helveticus, B longum are in combination. Here a single lactobacillus kg serota is utilized. Here bifidobacterium, bifidum, and different strains, lactobacillus acidophilus, lactobacillus brevis, lactobacillus kg, lactobacillus olivaricus, lactobacillus lactis. Different strains are utilized for different times, starting from 30 days to 4 weeks. And here we got positive results in human subjects, influenced brain activity in the center of emotion, less psychological distress is seen, improved mood is occurred, and reduction of rumination as well as aggressive cognition is seen. And here psychobiotics are used in human are a large number of lactobacillus or streptococcus or bifidobacterium in combination, they are diminishing or decreasing stress, depression, as well as anxiety. Such anxiety as well as depression uh, reduction, anger, hostility reduction, problem solving, and median urinary free cortisol level is decreased due to the application of L. helveticus strains or Bifidobacterium longum. Here, Bifidobacterium longum 171 strain is responsible for the reduction of depression as well as anxiety. And here are some examples which are showing and immunomodulatory action in case of mice, as well as similar action against depression, stress, and anxiety are also applicable in mice and tested in the mice model. Here, neuropsychiatric disorder, Alzheimer's, in rat model as well as in human patients, different types of lactobacillus or psychobacteric strains are utilized in different situation, and fecal gonulum reduced, fecalobacterium is increased. These are very good bacteria which are residing in our intestine, responsible for the secretion of butyric acid by other bacterial help, that is help of lactobacillus probiotic. Here we are seeing that in case of Alzheimer disease person, the disease symptoms are reduced due to the application of psychobiotics or probiotics. And here is a similar rat model which are getting similar result in relation to Alzheimer disease symptoms. Here, another disease which is related to central nervous system. This is Parkinson disease. Here, a large number of psychobiotic strains, starting from lactobacillus to bifidobacterium and other some strains. These are the probiotics utilized against Parkinson. So these are the psychobiotics. Here, 9 at least bacteria, probiotic bacteria, are utilized in combination. They are acting against dysbiosis in the intestine and inflammation in the brain. And so Parkinson symptoms are reduced. Here, the mechanism of action Parkinson disease, we are seeing that blood-brain barrier is disrupted in the nerve in the brain due to the inflammation in the intestine, and this is related to vagus nerve, that the signal is transmitted from intestine to the brain. So inflammation in the intestine is transmitted into the brain, and here alpha synuclein is produced. That means Parkinson disease pathologies are achieved. So dopaminergic neurons are activated, and here microglia activation, interleukin 1, tumor necrosis factor alpha, inducible nitric oxide synthesis is seen, so that Parkinson disease is caused, and the application of probiotics are responsible for the reduction of such disease symptoms and the restoration of brain function. Now, amid COVID-19 pandemic, due to COVID-19 for a long time, at least more nearly for 1 year, we are seeing that mental stress, anxiety, different types of neuropsychological disorders are achieved. So here probiotics in the form of cytobiotics may be utilized, because we know there is a link between dysbiosis in the gut and lung infection. So if we apply probiotics, such kind of dysbiosis may be diminished, and in some cases lactobacillus and bifidobacterium are utilized, so that the probiotics are very useful in COVID-19 as well as the neuropsychological disorder in relation to COVID-19. Here, some of the probiotics and prebiotics, collectively known as synbiotics, we have named already the bifidobacterium, lactobacillus, different type strains. Here the fructooligosaccharides and galactooligosaccharides. These are the very good examples of prebiotics. These act in combination. Here the gut wall, short chain fatty acids are formed, and here modulation of immune system pathway, neural pathway, and metabolic pathway is seen. Here increase of neurochemical substance, production of modulation of immune pathways, neuronal pathways, and metabolic pathways are seen, and so that the gut microbiota axis, microbiota gut brain axis is maintained well, and some the responsible components that are responsible for causing blood brain disruption are diminished due to the application of psychobiotics, and the good components are increased. So neuropsychological disorders, inflammation, Alzheimer disease, Parkinson disease, stress, mental health problem, anxiety and depression, and autism spectrum disease symptoms are diminished. So probiotics in the form of psychobiotics are very useful in diminishing the neuropsychological disorders. And here are some examples of prebiotics that are utilized against stresses in healthy as well as disorder person. Here are some examples of probiotics that were the prebiotics. These are utilized against in case of a healthy person as well as the Parkinson disease person also. And such utilization of psychobiotics maintain the gut brain axis as well as the removal of the blood-brain barrier as well as the dysbiosis in the microbial dysbiosis in the gut, and immune homeostasis is maintained due to the application of psychobiotics. So we are saying that symbiotics, which are in combination of prebiotics and probiotics, are utilized, and these are collectively called also psychobiotics because these are responsible for the reduction of neuropsychological disorder or the procurement curing of neuropsychological disorders. So psychobiotics, that means the probiotics, prebiotics in combination probiotics are applicable to get benefit against neuropsychological disorders. And these are the related publication in the field of lactobacillus probiotics. And ultimately, I acknowledge the Addiction Psychology 2020 webinar organizing committee for the recognition of my research and their invitation to this webinar. Thank you. Stay safe, ma'am. Hello.
Yeah, thank you, Dr. Shamapada Mandal, for your presentation. So,
Yes,
yeah, do
ma'am.
we have any questions or any comments? If anyone is interested to give any comments, then please go ahead. Or if you're having any questions, please do ask. Okay, I guess there are no questions, Dr. Shamapada Mandal. So, yeah, thanks a lot for your time and your presentation.
Thank you, ma'am.
So, yeah, moving on to our next presentation. It's from Dr. Mohammed Zubair Mia from Shazid Tajuddin Ahmed Medical College, India. So, yeah, Dr. Mohammed, please do click on the screen button present at the bottom so that you will be able to share your screen with us. Over there in the go-to meetings, please give the permissions. Maybe that'll help you out. Yeah.
Hello, I'm Dr. Mohammad Mia.
Yeah.
Hello, I am Dr. Mohammad Jubair
Yes,
Mia
doctor,
from
your voice is
Shohid
audible to
Tajuddin.
us.
Yes, Shohid Tajuddin Ahmad Medical College, Gazipur, Bangladesh. Please, you mentioned India, not in India. It is in
Yeah.
Bangladesh,
I'm sorry for that. Yeah, I'll
nearby
definitely
India.
change it.
Okay, okay. Uh, but I can't share my slide. Can as I am in mobile. I am in
What you
a
can do is you can just open your presentation at first and then come back to go to meetings and you will be able to share it because we also had so many people doing it in the mobile and yeah, that was working for them.
yes. Okay. At first, I open the file.
Yeah, first open the
Sorry.
file. Yeah,
Okay.
please open the file.
Uh, Then go to then join the meeting. Okay.
No, no, not like that. You can just open the file.
Okay. Okay.
So if when you open it, you will be able to like share it. Yeah, now you can just click on whatever file you are wishing to open because your documents are seeing like yeah.
Are you sorry? Can you show my slide?
A Word document was being opened right away. Like yeah, the Word document. Yeah, the Word document is visible to us.
Okay. A document, but not a slide. Sorry, I'm sending my
That even
PowerPoint
that will be
presentation.
visible. That will be visible. You just
Okay.
yeah, just open the
Can you
presentation.
see?
Yeah, now it's visible. Yeah, it's
Okay.
visible.
Open. It's visible. Okay. Uh, Now, can you see the slides now? Hello. Can you see the slides now?
Yeah, we can see it.
Okay. Thank you.
Yeah,
Sorry
it's
for the
visible.
interruption.
You can start with the presentation. Yeah, it's visible to
Okay.
us.
Okay. Okay. Uh, this is a case history of an epilepsy patient in Bangladesh. Mr. A from 50 years old. He is graduated and unemployed, middle-aged, hailing from a low socioeconomic family of a rural area from a northern district of Bangladesh. He complains of convulsion 2 to 3 times per week for about 1.5 years. According to caregiver, his wife, convulsion is associated with unconsciousness, and during convulsion, he gets trauma in different parts of the body during the fall. Frothy discharge through mouth. Convulsion is aggravating during long wakeful night. There is no family history of an psychiatric or neurological abnormalities. He was reasonably well during childhood. He has two daughters. No significant history of medical illness. He is smoker, but no history of any other substance use. He is extroverted. He used to play cards on leisure time. On general physical examination, it was revealed everything was normal. Systemic examination, including nervous system, was normal. Routine investigations was normal. Computer CT scan and imaging was revealed normal. EEG was revealed slow wave. Mental state examination revealed Middle-aged person with average body build, kempt, appearance and behavior was normal. Social behavior was maintained. Eye-to-eye contact was present. Repo was established. Speech was normal in rate, rhythm, and volume. Mood was euthymia. There was no suicidal or obsessional thoughts. He was conscious, oriented to time, place, and person. His memory was intact. His judgment was intact. His insight was present. At that time, diagnosis, our provisional diagnosis was generalized tonic-clonic seizure. And I started oxcarbamazepine, 300 milligram single dose, orally for 7 days. After 7 days, he came to me and complained that convulsion occur one time and only, but experienced no side effects of drugs. Then I advised to take oxcarbamazepine 300 milligram BID and told him to come after 1 month. There was no history of convulsion after 1 month. At the time of third visit, I advised him to take the medication with the dose of 600 milligram daily for 3 years. After 2 years, he came to me and was happy to say that he had no convulsion till now. In conclusion, it is observed that oxcarbamazepine is also effective in generalized tonic-clonic seizure as well as partial seizure. In every visit, every 3 months, I assessed his liver function test, his blood count, and his other parameters like cardiac status. Everything was normal. And so, in conclusion, I would like to say oxcarbamazepine is effective in generalized tonic-clonic seizure, also effective in partial seizure. This is my small case history, and thank you all. Hello. Hello. Yes.
Yes, Dr. Mohammed.
Hello. Yeah, yeah. Yes. Can you hear me?
Okay.
Uh, uh,
Yeah.
would you see my screen? No.
No, your screen is
Uh,
not visible.
sorry. Mm,
Yeah, it's visible now.
visible. Okay. Can you see my PowerPoint slide presentation slide?
No, not yet.
Oh, sorry. Can I speak? Continue my presentation without slide? Okay.
Yeah, sure,
It's
sure, you can
some.
do that.
Okay. Okay. Sorry for the interruption. For technical, this is a technical error. Um, I have in this presentation. I would like to present a case history of an epilepsy patient in Bangladesh. A 50 years old graduate male person hailing from a rural area of a northern district with the complaint of convulsion 2 to 3 times per week, And during convulsion, he used to fall and had some trauma in overhead and other parts of the body, and comes out through the discharge through mouth. All this history are crossed by his caregiver, his wife, uh, who saw at that time of seizure, observed him and supplement the history. After that, I go through EEG and shows there is slow wave, and I have done all the medical investigation to exclude other pathology, like I assess his cardiac status and his renal function, his liver function, and full blood count, and reveals all are normal. And I take thorough clinical examination and neurological examination. All are revealed normal. On mental state examination, a middle-aged person came and showing maintained normal social behavior, and his speech was normal, mood was euthymic, there was no perceptual abnormality, and his thought process was normal, and his insight and judgment was normal. And after that, I made a provisional diagnosis. He had been suffering from generalized tonic-clonic seizure. And then I prescribed him oxcarbamazepine 300 milligram daily for 1 week, and advised him to see any side effect and immediate report me. I told him to report me if any side effect occur. Fortunately, after 1 week, he came to me and complained that his seizure frequency was reduced, like 1 time per week, and there was no side effects of the oxcarbamazepine. Then I started 300 milligram oxcarbazepine BID for next 1 month. After 1 month, he came to me, complained no seizure, and there was no side effect of drugs. Then I advised him to come after 3 months, and I assessed his whole blood count, liver function test, and cardiac assessment. All were normal. And then I follow him up to 2 years, and he happily came to me to told me that there was no history of seizure, and I advised him to take medicine at least 3 years, and he sometimes contact with me over phone, and finally after 3 years he came with his wife and told me that, doctor, I am now seizure free. How can I do? How would I stop medicine? Then I advised him to reduce medicine, and I prescribed the doses, tapering the doses. Like at first, I reduced 300 milligram at 1 time, and then 200 milligram, 300 milligram 1 time for 3 months, then 200 milligram 1 time at bedtime for another 3 months, and after 3.5 years, uh, I advised him to stop the drug and take precautionary measure to which stimulates seizure. Like I advised him to avoid awakening overnight, long time awakening, and long time see the screen like TV, computer. I advised to stop this type of habits, and advised him not to go in the water in the water or in journey without any person's help. And after 1 year, he happily told me that after 1 year drug-free period, he had no seizure. And in my conclusion, I observed that oxcarbazepine is a good drug for generalized tonic-clonic seizure as well as in partial seizure. Usually, we prescribe sodium valproate with valproic acid in generalized tonic-clonic seizure, and we prescribe oxcarbazepine in partial seizure. But I observed that oxcarbazepine is also effective and in the generalized tonic-clonic seizure. Thank you all for patient sharing. This is my case report.
Thank you.
Hello.
Thank you for your
Yeah.
presentation. Thank you for your case report.
Welcome. You are
So,
welcome.
yeah, do we have any questions? So, I guess there are no questions. Okay, so yeah, let's move on to our next presentation. And for our next presentation, we have Dr. Islam MF from Prayosh, Bangladesh. So, Dr. Islam, please click on the screen button so that you will be able to share your screen with us. Dr. Muhammad Farooq Islam, yeah, thank
Yeah,
you.
it's a good afternoon here. Assalamu alaikum.
Mhm.
So share my screen. Mhm. Yeah, is it okay?
Yeah, your screen is visible, but a very black screen. Just give us a moment. Only a black screen is visible, not with the content. I'm sorry. Yeah, now it's visible.
Excuse me, I have to leave. I have important issues. So thank you all.
Sure. Sure. Thank you. Thanks a lot, Dr. Muhammad.
Thank you. Thank you.
So is it visible, doctor? Yeah,
Yeah, your screen is visible to us, Dr. Farooq Islam.
but I can't see it here.
Oh, okay. You will have the GoToMeetings icons, maybe. Am I correct? Is that the problem?
Mm, check. Okay. You can see my presentation now, no?
Yeah, we can see it.
Okay, I will go outside. I think you can start in by side, no problem. Sound is clear, doctor?
Yeah, sound is clear.
Okay. Can I move to next? Probably network is very poor here.
Okay.
So I think I should start. So thank you for giving me time,
Yeah, we
and I must say thank you all organizing team to invite me in this program today. So that's why I'm really thankful. So I am Mr. Farooqul Islam, working in Bangladesh in a rehabilitation hospital where a lot of neurological disorder patients are being rehabilitated within the as an active member of the team. I work here as a consultant physical therapist. So I have been listening so many presentations. So that was a neurophysiological and neuropharmacological and neurobiomechanical biochemical problems. So that's really giving me a appetite to listen interestingly, because that's giving me a very pleasure. So I will talk a little bit different than this. So that's all about the stroke, where I have been select there is a stroke, the habitual. The title of my thesis I will go to present here today: habitual physical activities and its relation with CVA, bus or cerebrovascular accident. Can you listen to me?
Okay. I'm sorry for the
So
inconvenience. Just a moment. I'm just trying to mute. Uh, Dr. Farooq Islam, could you please unmute your thing, because I've muted everyone. So please try to unmute. Yeah. Now, yeah, we can listen to you.
the skin is visible, doctor.
Yeah, the screen is visible.
Okay.
Yeah.
So today I'm going to talk about. In fact, I have been listening so many presentations that was absolutely interesting to me, especially because they are talking about and discussing a neurophysiological and neurochemical or neuro biomechanical some changes around our brain and nervous system. So I will talk a different than these. I must say, and that the how. Habitual physical activities can lead a person to have a cerebrovascular accident or stroke. That's I'm going to talk today with you. So we know the physical cerebrovascular accident is one of the major problem in global or stroke. That is uh, and number third immediate after stroke and after heart attack and cancer in globally. So in Bangladesh, this is also a common phenomenon because stroke nowadays in Bangladesh is coming in number one. In 2017, the research from Lancet had published that the number one killer in Bangladesh because of stroke or cerebrovascular accident. So my study were how does it leads to people having a stroke. There are so many uh, contextual factors are being involved. That we know, and the devastating effect of the stroke we know very beginning. How does it affect individuals' physical, psychological, biopsychosocial, and economical life from beginning of the stroke to end of their until back to community. So my study title were physical habitual physical activities and its relation about stroke. So habitual physical activity, the study I had took in a rehabilitation hospital in Dhaka. So here I have collect a sample, and that was 135 sample I chose those who already have a stroke, and they went through a rehabilitation protocol where a pre-set of questionnaire being asked to them about their habitual physical activities before stroke, and how does that affect in now at the moment after stroke? So can you see my screen? So my sample size what I have selected is supposed to be a 3 to 3, but due to examination I took only 135 sample. The inclusion criteria what I have chosen: patient who are suffering cerebral both acute and chronic. Patient the age range were 20 to 80 years. Patient having good communication skill and memory. Both gender are being involved in my research. So the study methodology was cross-sectional retrospective study that I carried out here. So ethical permission I taken from the ethical committee to conduct the study, and all procedure have been maintained, and the patient confidentiality and other ethical issues has been properly guided, as an informed consent and other accessories being maintained properly. So the my study what I have found, as you know, the globally stroke is one of the best devastating effect brings to individual lifestyle. There are so many studies about it, both the developed and developing nation. So here in Bangladesh, Bangladesh is one of the least developed country at the moment, and developing country where people are still are living hand to mouth in the rural area. So stroke changes their lifestyle, their physical status, their psychosocial status. So it affects their whole, I mean, holistically in both way in their life phenomena. And the rehabilitation service is inadequate at all level. I mean, people can have ability only they can afford, because still government are planning to implement the rehabilitation service at rural level. So at the moment there are scarcity in rural level to have this service, but in the urban people can have the service with their payment. So that's why the inadequate service are available at moment. So that's also make a person to suffer more. So my study results have shown that the maximum male female ratio is 76% were male and female were 23%. So that was my male female ratio. And if I go to some slide, escape. So there are some scale I have been used. So the scale which are to measure the socio-economic status, I use Tupasumi socio-economic classification scale. In that scale, I have found that the maximum people are suffering, those who are middle lower level people. They suffer more stroke rather than high class society. So that is
I'm going to
that
write
scale
Right.
that scale have shown in some socioeconomic measurement which I have been used in my research.
तो नंबर दीजिए
So our male female ratio that I have seen here, and there is a maximum people are in the lower middle age group. So in the middle age people they suffer more stroke. In the research that also they supported that the people are suffering in the middle age in here. So in the work relation, as I have told about the habitual physical activities, I have found those who work, I mean, as heavier stroke, as heavier objects, their nature of activities are heavier, as heavier, so they suffered more. I have found and much heavier, where I have found less people, and then much lighter work who are continue. I found they are less in stroke. So that's also a clue which group, which type of activities, what type of activities leads people to have a cerebrovascular accident. So most interestingly, I found in leisure time activities. Leisure time activities that's giving me very interesting that I found that those who are watching TV in during leisure time. So they are very prone to have stroke rather than those who exercise or do some physical activities, walking during leisure time. So they are will be less stroke rather than those who pass their leisure time in seeing a stroke, watching a TV. So that's me give me very interesting. As you know, Bangladeshi people they are doing very hard work, and they are not quite prompt to doing physical activities. Other than what when they have a time, they try to take leisure. I mean, watching TV or sitting or not doing any exercise. Usually they are not very prone to exercise. So my study has indicated that there are those who watch TV and in their leisure time they have got more stroke rather than the group of walking during this leisure time. So in next slide. Is it visible screen, Dr. Jessica?
Yeah, it's visible.
Then the point I'm discussing about at the discussion point, what I have found that the evidence found that by Dr. Khanam, at the age of one, the risk factor is to more age person are more prevalent to suffer from the stroke. Uh, a cross-sectional study have found in Bangladesh, which conducted among the person age group more or less than 60 years, found that the group has suffered multi-morbidity disease. For instance, stroke is one of them. So as I have told earlier that the Middle East group people, I mean here in Bangladesh, they suffer more stroke. And if you ask me why, it is not prevalent. Probably the older person, as you know, in Bangladesh at the moment their age higher age range is 60 to between 70. So their average age group. So probably that's why, or the maximum age group, they are not coming in under treatment. Probably that could be the reason. So another study found that show the more than 60 years are more suffer than severe than the young is less than 60 years. So as the evidence show that male are the more prominent to stroke than female. And my study also found the similar, the male are more prominent in stroke. Another study found that 56% who suffer from the CBA who have a left side hemisphere, while 43% female they got CBA with the right side hemisphere. So there are different way I try to correlate with the different factors and different variables. I try to correlate how does and what could be the reason having this stroke, and how does it affect their habitual physical activities. I mean their lifestyle from the beginning. So moreover, it has found that the walking during leisure time, more than around 55% they use work sometimes, where only 3% had stood are always used to work. So that means those who never work during leisure time, the maximum number they got stroke, where they work in the leisure time. I found in study 3% only having stroke. So the study suggested by the Mori that there is a positive association between leisure time physical activities and CBA. That's the evidence that supported. So it is established by the research and the scientists that habitual physical activity or active lifestyle reduce the risk factor of stroke. In contrast, sedentary lifestyle or less physical activities impact on individuals' health and often causes impairment and disabilities. So so my conclusion point it was that study finds show the people who were involved in the more physical activities or who continued active daily life either in working area or home, they suffered less percentage of cerebrovascular accident or stroke compared with the inactivity group. And second point is the conclusion I must tell you, a physical active lifestyle reduces the risk of all cause mortality, and chronic disease, including stroke. As you know, the nowadays world, at the moment, world is striving for the non-communicable disease. And the communicable disease era has been certainly minimized. But unfortunately, the non-communicable disease are in the apex. So that's why the stroke is among one of them. So my study have found this the same scenario. That's what I have mentioned. What I have found also in literature. So in contrast, physical inactivity. I mean, not a lack of physical activity, but prevalence of sedentary behavior such as sitting or lying reduces life expectancy and increased risk worldwide of cardiovascular and metabolic disease up to 10%. That's very interesting. Interesting things I have found in my study. So physical inactivity. I mean, not lack of physical activity, but prevalence of sedentary behavior. Those who are usually, I told you, as a South Asian people here, maximum people they try to lead sedentary behavior or sedentary lifestyle. So their lifestyle is quite leads to have which reduces their life expectancy and increase the risk worldwide because that up to 10%, that's very alarming. I must say very alarming for the population like us in here in South Asia or in Bangladesh. So my study has recommended at some point. I recommended that this cross-sectional study I conduct for my academic purpose in a master's for obtain a master's degree. So I recommended this study can be done in a broad spectrum. I mean, longitudinal study. A longitudinal study can be conducted with a mass sample size, which so actual figure that can be prevail. What could be the scenario? What could be the next steps a professionals or policymaker can do? So that was one of my recommendation. And second recommendation were use some more skills to measure their activities in PBS before stroke. I mean, how does they lead behavior? How does they conduct? How does they continue their life? And what are the at the moment the present status? So different types of measurement tools can be used by the longitudinal study throughout some years. So that could be the actual figure can be sorted out rather than or the study design can be changed to find the actual figure like cohort study or observing study for following years. I mean, so many years can conduct. So actual figure that time can be included. So at the end, I must tell. So this study giving us a alarm for the people like us to lead active lifestyle rather than inactivity or lack of physical activity. And nowadays, as you know, our technology, I mean, mobile or social media, social communication make people more sedentary lifestyle. And within the pandemic situation at the moment, as the world is striving or suffering, so that also causes. I must tell you, I'm sure that people at this that range will be increases. Uh, Cardiovascular disease or stroke or non-communicable disease because of the inactivity and people are almost use their life incidentarily at moment because of their worldwide COVID scenario. So that was all about my presentation today. So I would expect any comments from valuable guests and participants. So thank you very much.
Thanks a lot, Dr. Farooq Islam, for your presentation and your time. So yeah, do we have any comments or questions that you'll have to shoot in for Dr. Farooq? Okay, I guess there are no questions or comments. Yeah. Thanks a lot once again. Yeah. So moving on
Thank
to
you
our
very much.
next presentation, we have Dr. Lee from Hopkins University. Yeah.
Hello, good morning,
Dr.
everybody.
Good morning, Doctor. So yeah, please click on the screen button so you will be able to share your screen with
Yeah,
us.
that's I'm working on that now.
Sure, thank you.
All right. Hopefully everybody can see see the
Yeah, that's
screen.
perfect.
Wonderful. All right. Well, thank you all for having me today. I'm Lee Axe from Johns Hopkins. I'm an otolaryngologist. I'm not a neurologist. I manage voice and swallow disorders, and I'm here to talk about management of hypophonia and Parkinson's disease. And we're going to talk about what the role is for injection augmentation in particular. I don't have any relevant disclosures to today's talk. And we're going to want to talk about what the role of voice handicap is in Parkinson's disease. We're going to review treatment for that. And I really want to focus as much as I can on the procedural aspects of treatment, the vocal fold augmentation, which is something that in practice I can offer to Parkinson's patients with dysphonia. And we'll talk about the theory behind it, but also the practice and the data to show whether this is or is not effective.
I'm sorry to interrupt you, Dr. Lee, but the presentation is actually, we are only able to view the half part of your presentation. I'm sorry to interrupt. Yeah.
What about now? Is it better?
Yeah, now it's better.
Okay. So let me ask then, how many in the audience are neurologists? And I imagine typically when I do this in person, we can get a show of hands, but I imagine most of the people, given the nature of the topic. And so I imagine most of you routinely care for Parkinson's disease patients in a different way, of course, than I do. How many of you ask routinely about voice quality of life among your Parkinson's patients? And how many routinely refer these patients to otolaryngology to address those voice concerns? And hopefully, if you're not doing that now, by the end of the presentation, you'll see the need perhaps to do it. So we know that there are a lot of communication difficulties in Parkinson's disease. Some of these are speech related rather than voice related, and we draw a distinction in otolaryngology between the two. Speech being things like rate and fluency. Stuttering, for instance, is a speech disorder rather than a voice disorder. Dysarthria is a speech disorder rather than a voice disorder. And that is speech is generated, of course, from the central nervous system, coordination of the articulators, lips, teeth, tongue, things that aid with pronunciation. Voice, by contrast, is a laryngeal function. It is the vibration of that air column you see diagrammed in the photograph coming from the trachea between the paired vocal cords. Vocal cords begin to vibrate. That vibration creates sound. And that sound has characteristics such as volume, breathiness, roughness, pitch. Those are laryngeal functions. And we know that patients with Parkinson's disease have both speech and voice disturbance, that the overall bradykinesia, muscle rigidity, postural instability, and the rest feed into vocal tremor, diminished projection, that's a voice quality, scanning speech, those bursts of utterance at low volume with delayed onset, things like that, those are speech disturbances. A mumbled articulation is a speech disturbance. So these patients with Parkinson's often have both speech and voice disorders. And up to 90% of patients with Parkinson's will complain of dysphonia during the course of their disease. And nearly 1 in 3 will cite a change in voice or speech as the most debilitating deficit related to their disease. As an anecdotal aside, I can say that unfortunately, I'm in the position sometimes to suspect the diagnosis of Parkinson's before the patient's ever seen neurology, because it's a voice disorder that leads them to seek medical care. And when I recognize a characteristic hypophonia that suggests Parkinson's, and then I start looking for change in gait and tremor and rigidity and masked faces, I oftentimes, because they will present with the voice complaint first, suspect Parkinson's disease and then send them to neurology. This is what normal vocal cord motion looks like. So this is how we evaluate the vocal cords in the office. The camera in through this patient's mouth and looking down at the voice box. We have a view of the anterior larynx and posterior larynx, the right vocal cord and the left vocal cord. And those vocal cords will open during breathing to allow air to go between them to get to the lungs. They will close during speech. And when you push air between the vocal cords, the air will push the vocal cords into vibration. So for normal voice with normal vocal cords, vocal cord motion is symmetric, closure is complete, and you get a symmetric even vibration. So that's what normal is. In Parkinson's, we know that unfortunately these patients don't always appear normal on exam. They don't have lesions. You can see that these vocal cords don't have any nodules or polyps or growths, but oftentimes they'll represent both some thinning and bowing with loss to muscle mass, and more than half will also have vocal cord tremor. They'll show reduced coordination, and between the reduced coordination, instead of smoothly closing and opening symmetrically, we get a little bit of a stutter step kind of motion. They often then have poor closure with some breathy air escape during speech, and the more air that leaks out between the vocal cords, the less entrained vibration is generated on a single breath. They're simply inefficient with their voice, in the way that a vocal cord paralysis patient might be inefficient aerodynamically with their voice. So this is a Parkinson's patient with impaired closure and that little bit of a stutter step pattern to opening and closing with reduced symmetry. And some of those changes are effort dependent. So when I asked for very loud voice, we saw that closure, while not perfect, was better, that volume was better when they made the effort to drive enough air. So we know in general that patients with Parkinson's disease have that bowing, have that tremor, have that asymmetry and discoordinated closure, but they also have some vocal cord stiffness, that it takes more pressure, more subglottic pressure, more pressure from the lungs driving that air between the vocal cords to generate flow. And it might be that this increased pressure relates to, again, the muscle rigidity, even at the level of the vocal cords. And we know that this impacts their overall quality of life. So Parkinson's patients will have a reduced voice quality of life overall. We'll see that that voice quality of life will get worse as Parkinson's disease progresses, that the worst or the worst quality of life they have relative to Parkinson's, the voice changes will mirror that. You see the slope of this curve has a positive trend. And we know that as voice quality of life gets worse, swallowing quality of life will also get worse. And we know that all of these changes can cause communication disorder, which then can create depression. So when you take a look at Parkinson's patients, patients who have dysphonia with Parkinson's, dysphonia plus patients, seem to be more depressed overall than Parkinson's patients at similar levels of Parkinson's disease otherwise, but who don't have dysphonia. And that relationship between dysphonia and depression gets stronger as severity increases for both the Parkinson's and the dysphonia. And that relationship between dysphonia and depression is stronger than the relationship between dysphonia and the severity of Parkinson's disease itself, meaning that it really is the voice disturbance driving the depression as much or more than severity of Parkinson's otherwise. So we know that this dysphonia is real. We know that it is the presenting complaint for a lot of patients. We know that it handicaps their quality of life significantly. What can we do about it? Treatment can really have behavioral, medical, and surgical aspects. I'm going to really leave the medical aspects to you guys, neurologists and dopamine agonists, carbidopa, L-dopa. You guys are the ones who are treating medically, and I'm rarely prescribing a medication for these patients, but I am routinely prescribing behavioral treatments, speech language pathology evaluation, and voice therapy, and we'll talk about voice therapy. And I'm also offering procedural, I should say procedural rather than surgical, because oftentimes it's done in the office, but procedural approaches to improving strength of voice and improving projection. So here's what we know about behavioral treatment. Lee Silverman voice therapy is abbreviated LSVT. It is a trademarked type of voice therapy given to patients with Parkinson's disease. Lee Silverman voice therapy is named after one of the first patients to receive this treatment, Lee Silverman. So that's not the name of a therapist, it's not the name of a speech pathologist or a physician, it was actually the name of a patient who received this treatment. And we know that in randomized controlled trials, and this is a systematic review on the right, and one of their data tables with, you can see, each of the references, and I realize it shows up small, but there's a really large evidence base that Lee Silverman voice therapy, encouraging patients to get loud, to practice being loud, gives them significantly better sound pressure levels, gives them better speech rate, improves the monotone nature of their speech, their intelligibility, as well as their projection. And this positive benefit has been documented with acoustic measures, rate, articulation, and the rest, but also perceptual measures where a listener listens to the voice and provides their own report of voice quality and loudness and roughness, and physiologic measures seen on electroglottography, for instance, or direct visualization of vocal cord closure. So there are a number of different ways we can document the improvement in speech, but we know that LSVT works. And a routine audit of patients who've had LSVT, however, we know that that benefit may fall off over time. That sustained vowel volume, reading volume, voice handicap index, all these got better after voice therapy. Some of these changes may persist at 12 and 24 months, but that reading volume, when you're not coaching them into a loud sustained vowel, but when they're simply producing their native voice, that falls back to baseline at 12 or 24 months. And that voice handicap index, which is better at 12 months, falls back to baseline by 24 months. And so that raises the point that we need to continue to encourage these behavioral approaches to loud voice in these patients. Cochrane meta-analysis, there's so much data for Lee Silverman voice therapy compared to other types of voice therapy that there's actually been Cochrane meta-analysis that looks at this and says that although improvements in speech are noted, due to the small number of patients, methodological flaws of the studies, possibility of publication bias, insufficient evidence to conclude that, that there's efficacy for speech therapy for speech problems in Parkinson's disease. Now, clinically, we see that it's there, and again, I showed you the other systematic review, but this speaks to the level of data that we have. And in a interventional field with procedures or voice therapy, particularly in ENT rather than neurology, we don't have lots of randomized control trials. And if you do a meta-analysis that looks only at prospective data, that looks only at randomized controlled trials, you're going to find that evidence in general is lacking because we have a lot of cohort studies instead. And consider, as I say this, that as much as we know about LSVT and as effective as we think it is, if this is what Cochrane says, consider that the data for LSVT is much better than the data I will present next for the procedural interventions we can offer. Before I move to the procedural interventions, let me just make one quick statement about behavioral treatments and what's new and what's coming. There are these vocal monitors. You can see the transducer here taped to the front of the neck, this ambulatory phonation monitor. These are commercially available. They do not record voice. They do not record the content of speech, but they can infer from the strength of vibration at the anterior neck the loudness of speech. And you can set these to have a certain tactile feedback, a buzzer on the hip-worn aspect of the device that when the patient is mumbling, when the patient is too quiet, the device will vibrate and be a physical cue for them to get loud again. And so there are ways to supplement the behavioral approaches with ongoing cueing with this on-the-go vocal monitoring. Medical therapy, as I said, I'm going to defer to the neurologist in terms of the particulars of medication and how much to prescribe and when. But we know that there are some studies that show that when patients with Parkinson's are placed on these dopamine agonists, that their voice will improve, and that improvements in vocal intensity, duration of entrained speech will parallel the improvement in bradykinesia, rigidity, and other motor activities with better intelligibility and higher subjective voice quality of life. evidence is a little bit of mixed evidence, and it's not a foregone conclusion that everyone will get better with dopamine. But if they do improve systemically, voice improvement is in general part of that. In terms of the procedural things that I'd like to focus on, we're really talking about vocal fold augmentation. And the theory is that in that stutter stepping, thin bowed closure that I showed earlier, that there's a gap there. And that a gap gets in the way of efficient sound production from a physiologic level. That the more air that leaks out, the less air is being used to entrain vibration, which is where loudness comes from and where clarity comes from. And so that a breathy voice makes for a quiet voice, an effortful voice, and a rough voice, and that correcting the gap so that air is more efficiently translated into vibration can address some of the voice complaints in Parkinson's disease, not the speech complaints, not the articulation, not the scanning speech, not some of those other things, but instead the voice production, the loudness, the effort, the clarity rather than roughness. Medialization can often be done in the office. It's an awake procedure in the office and can be repeated multiple times as changes occur in patient need. Medialization can also be done in the operating room. If we do it with a medialization implant, it's often done just the once because now it requires neck surgery, an incision in the neck, a surgical procedure with an overnight hospital stay. And while those implants can be tuned again and again and again, most patients prefer that they not need to be tuned, and so we try to do it just the once. So here's a case study that I think nicely shows some of the issues with injection augmentation of the vocal folds. This 73-year-old gentleman was a physician. As it turns out, he was actually an otolaryngologist, and he came to see me, self-referred because he knew I specialized in voice, for the chief complaint of reduced projection, reduced volume. And he had associated complaints of voice getting rough and needing to work harder to speak. And he had thought himself to have reflux, because that's often what non-voice specialists in ENT will blame voice disorders on. He'd had one of his colleagues in his own practice scope him and tell him there are no nodules, there are no polyps, there's no paralysis. Your voice complaints must be related to reflux. What's interesting is that there's a family history here of Parkinson's. So this otolaryngologist with a family history of Parkinson's disease, who, when you ask, also endorses some change in handwriting, is complaining of reduced volume and roughness in speech, shows, at least on my exam, to have a shuffling gait, even though he's denying gait change, has a very characteristic masked faces, had never thought that Parkinson's could be responsible for his voice disorder. Exam, with that characteristic discoordination, one vocal cord closing before the other, thinning and bowing of the vocal folds, a little bit of tremor at abduction, and a gap between the vocal cords when he's trying to voice, which is again effort dependent. So I'll see if I stop talking. If you can hear his voice get louder. And so there's the better closures, he gets loud. And so he wanted injection augmentation. When we showed him the bowing and the gap on phonation, I suggested to him that this might be Parkinson's, suggested to him that he perhaps have neurologic evaluation, and he said, I'd like an injection. So here's what that procedure looks like. And so this same view of the larynx, cameras coming in, is looking down at the vocal cords, shows a transoral needle, a needle that's inserted through the mouth, around the back of the tongue, and into the throat, where we can see it enter the field of view. And looking at the monitor, looking at the TV screen as the patient's awake and sitting in the chair in front of me, I can guide this needle into the vocal cords. I'm injecting with a filler. I'm injecting with a filler in this case, which is temporary. This is a carboxymethylcellulose gelatin filler. It's approved for vocal cord injection. It lasts typically about 2 to 3 months. And we're doing this as a proof of principle. He wants to see if better vocal cord closure provides for him better voice. You can see as the needle goes in, the vocal cord becomes thicker. And so we're trying to take this situation, and we're making the vocal cords thicker, create this situation. So we can see that in fact vocal cords are thicker. You can see that from concave, they are now convex, that there's less air leak. There's certainly some inflammation. I wouldn't expect voice to be better at the moment we finish injection, but we can see that the shape of the vocal cords is better as we finish injection. And so he came back to me, that was in October of 2014. He came back to me in February of 2015, said that was really good. It helped my voice. I was quite a bit better, but I was only better for a few weeks. I think the material wore off, and can we repeat it with a longer term filler? So CAHA is our abbreviation for calcium hydroxylapatite. It is calcium microspheres. Those particles are microscopic. They are suspended in a gelatin matrix so that we can actually squeeze them through the needle. It has the consistency of toothpaste, but as the gelatin carrier disappears, the calcium particles last, and the calcium particles last for roughly 12 to 15 months before the body can break down those spheres of calcium. So the temporary injection had offered some help. He said, give me the long-term injection. And so here's the needle with the calcium. And again, we're making the vocal cords thicker. Now, as I'm doing this, I'm asking him, have you seen neurology yet? Have you had an official diagnosis yet of Parkinson's? Have you been working with voice therapy yet? And he has said no to these questions. He's slow to do these things. I think largely because he's still in practice and he's not wanting to admit to himself or to his family or to his patients that perhaps he does have Parkinson's like his father had. But you can see again, the shape of vocal cords has become convex. Yes, convex rather than concave. He comes back to me in October. I do this injection in February. I say, this is going to last for you a year. I'll see you in about 12 months. He comes back about 8 months later, says voice was really good for 4 months, but then it faded away again. Asks if we can do another injection procedure. And it's striking to me that I know that the calcium should last longer than 4 months. And why is his voice fading away again? And I'm thinking in that Parkinson's way, is he down-regulating effort? Is he not putting enough breath behind his voice? Does he really need voice therapy? And I'm asking him again, have you worked with a voice therapist? Yes. Are they doing LSVT therapy? No, because I don't have a Parkinson's diagnosis. Why not? Because I haven't yet seen a neurologist. So this is now a year after his initial presentation. This is his pre-injection strobe. Vocal cords are closing better than they were when I had first met him. They're closing better because some of that calcium is still in place. It might be that we're beginning to experience some resorption, but clearly there's some calcium that's still in place, even though he finds that voice is getting worse. The nice thing about these injections is that they can continue to be done in consecutive fashion, even if some of the calcium is still there. And so we put more in. It's like filling up a glass of water. If you drink it partway down, but wish to fill it up again, you don't have to finish the glass before you pour more water. So we add more calcium to his vocal cords at his request. Vocal cords become thicker again. He leaves the office with better vocal cord closure and a voice which he feels is stronger, and he's happy. And the recommendation is, that's great. This should again last a year. But as you have this material in place, please see a speech pathologist, please see a neurologist. And you can see the change in shape of the vocal cords with a nice fullness to the inner edges. He comes back to see me in April. Now it's about 6 months after that visit. Says again, voice was really good for 4 months, but then returned to baseline. Still has not seen a neurologist, he says, but it's scheduled for next week. Can you do another injection? Every time I get an injection, my voice is helpful. Can we just keep injecting? And the answer, of course, is we can, but injection alone isn't going to help if you're not going to use the behavioral approaches to treatment to try to get louder. And again, would you benefit from a dopamine agonist? And let's get you into the hands of a neurologist who can tell us that. So overall, with these injections, and that last video was from 2016, I've seen him any number of times since, and he continues to present every 6 to 12 months for injection. He has had neurology evaluation. They've confirmed a Parkinson's diagnosis. So dopamine did provide benefit, and the Lee Silverman therapy provided benefit. And he finds that when he tries to get loud, he's better than when he doesn't. So these are all complementary approaches. One cannot by itself be as effective as all of them together. And so with injection, I feel a little bit like Sisyphus. I feel like I'm helping to roll the boulder up the hill. We're accomplishing something. But as soon as we stop, as soon as we say we're done, you've got your injection, you don't need to worry about neurology evaluation or dopamine anymore. You don't need to worry about using appropriate breath support anymore. Everything kind of comes right back to where we started, and it becomes frustrating, especially for a specialty like mine, which is much less used to dealing with chronic disease than perhaps your specialty is. We like to fix people, and we like to fix people with one surgery that fixes them once without the thought that this is a chronic ongoing problem. I still think these injections are very worthwhile, and patients do get a stronger voice for a period of time, but I counsel them that it's not meant to be a permanent fix. And I know that oftentimes that's what they're looking for. So what is the data? If you know, I've showed you one patient's experience, what is the data on vocal cord injection? It's limited, especially limited by lack of long-term follow-up. And the question we have is, as the material's still there, as calcium lasts a year, but vocal benefit lasts 4 months, is it because the patients get used to a certain level of volume and effort, and then in that bradykinetic fashion, do they down-regulate, downscale the degree of effort that they're making? So there are a number of different studies which have looked at this. This study of 35 patients did a phone survey after injection. 75% of patients reported satisfaction or improvement in their voice, and average benefit was about 3 months, even though the injectable used in that study, collagen, typically is expected to last 6 to 9 months. The patients who did worse were the ones who were most severe to begin with, particularly with speech deficits, with pronunciation or complete absence of initiation of speech. So we can make the conversion of breath to voice more efficient at the level of the larynx, but we're not going to change CNS issues as relates to initiation of speech, prosody, pacing, stuttering, scanning speech, things like that. And we're not going to change articulation by doing these vocal cord injections. Another study a couple years later looked at 18 patients, reviewed post-injection stroboscopy, and showed better closure. But again, patients are reporting benefit of 3 months, even though the material's in theory lasting 6 to 9 months. Of the patients who didn't get better, most of them had a central nervous system speech disorder with reduced initiation of speech. So their voices were subjectively louder when used. Relative lack of speech effort made the effective injection negligible. So again, know what it is you're fixing. You're fixing glottic competency, glottic efficiency, but you're not changing CNS and you're not changing articulation. Study the following year looked at 12 patients with some structured interviews and found benefit again with repeated collagen injections. Most of these patients are reporting an average benefit of 13 weeks, so 3.5 months, even though the material should be lasting longer. And a couple years later, a patient study of 6 patients, but now prospectively rather than looking only at post-intervention time points, did pre to post comparisons and found that 5 of their 6 patients improved on things like the voice handicap index, maximum phonation time, and pitch range, objective measures of voice quality that we can listen to, that the patient can report, and that we can actually measure in the office. More recently, a few years ago, 24 patients, retrospective study, 8 with vocal cord augmentation, 5 of whom had injection, 3 of whom had the implants done in the operating room, and 6 of those 8 had improvement in loudness. What's missing is long-term data, okay? And what's missing is a long-term data for repeated injections over time or with the medialization implants. And the question is, again, do these patients habituate to their new degree of closure, and do they begin to down-regulate their effort again when they get used to this new normal? And I think that they do. I think that's why we only get 3 months of injection benefit from materials that last 6 months, or 4 to 5 months of injection benefit from materials that last 12 months. And so we need to keep doing voice therapy. It remains effort dependent. It doesn't address pace, initiation, or pronunciation. And we don't know if injection can provide long-term benefit even with repeated injection. So we need to keep helping them behaviorally, even as we offer vocal cord injection augmentation. Understand that the most severely handicapped patients may not benefit as much, and the patients who don't have any handicap may not need it at all. So there is a sweet spot there for those patients who are symptomatic but not too symptomatic, not aphonic. And in that setting, it should certainly be considered. And so I'd recommend to all of my neurology colleagues, if you've got a patient with Parkinson's who's complaining of voice or complaining of swallow, please partner with your otolaryngology colleagues to consider evaluation of closure and discussion of whether it should be assisted with an injection. You saw the procedures, they're safe procedures, they're done largely in the office, there's no morbidity to them other than some coughing and gagging at the time of the procedure, and there's little reason not to do it if a patient is symptomatic. What do we need to do? I'm sorry for the technical difficulties. Hopefully I'm sharing again. That was a calendar reminder that popped up and got in the way. Whoop. Almost at the end. What do we need to do? We need to keep evaluating them for injection. We need to keep hammering the behavioral therapy. We need to partner together to try to help these patients get better. We need to collect long-term data, which happens by building robust data sets that involve the cooperation and collaboration between our two specialties. So that was the last content slide. The rest are references, and I'm happy to entertain any questions.
Thanks a lot, Dr. Lee, for your time on your presentation. So yeah, do we have any questions or any comments or anything you would like to ask Dr. Lee? I guess there are no questions, but yeah, it was interesting. Thanks a lot for your time. Thank you. So moving on to our next presentation, we have Dr. Seema Rohila from PGIMS India. One moment.
Hello, everybody. Should I go ahead with the presentation?
Yeah, you can. Please click on the screen button so you'll be able to share your screen with us.
Is it okay?
Yeah, it's visible.
But I missed so many.
Oh, okay. I think you will find two arrow marks facing the other side, opposite side. Just click on that and it'll get shrinked off.
No, it's not. Yeah, it shrinks a little bit. Yeah.
Hmm.
So, what I'm going to talk today is imaging in imaging in metabolic brain disorders, approach and current concepts. It's not about any particular disease, and it's basically how we should approach to diagnose these difficult type of entities. And it's quite common to see these type of patients, and they are very commonly confused with the hypoxic ischemic encephalopathy in children. So, with the background, the metabolic brain disorders are a major cause of neurodevelopmental disabilities, and these are difficult to diagnose, most often confused with perinatal insufficiency encephalopathy. Actually, just a second. Sure, it's better now. So metabolic brain disorders are a major cause of neurodevelopmental delay and intellectual disability. These are difficult to diagnose, most often confused with perinatal insults like hypoxic ischemic encephalopathy, kernicterus, and infectious diseases like TORCH, that is toxoplasma, rubella, cytomegalovirus, and herpes infections. The study was undertaken to develop an approach to diagnose or at least suggest metabolic brain disorders on MRI. So our objective was to characterize various metabolic brain disorders in children below 14 years of age, and 63 subjects were included in the study, and the age range was 20 days to 8 years of life, which were visiting the hospital and had clinical suspicion of metabolic brain disorders. All the children underwent MRI on 1.5 Tesla MRI machine from Philips, and in addition to the basics T1, T2 weighted and FLAIR weighted sequences, diffusion weighted imaging and proton spectroscopy were done. Out of 63 patients, we saw these patients, that is 15 were with metachromatic leukodystrophy, 11 had alpha-hydroxyglutaric aciduria, Wilson's disease in 4, Vanderknapp in 4, vanishing white matter disease in 5 patients, urea cycle disorders in 2, Menkes-Kinkeher disease in 2, methylmalonic aciduria in 3, Krabbe's disease in 3, Hurlow disease in 2, mitochondrial disorders in 6, and homocystinuria and Tay-Sachs disease in 1 each. We concluded that if we follow a proper and methodical approach in reading MRI, we can give a fair report about the presence and type of metabolic disorders and can be diagnostic in some entities like alpha-hydroxyglutaric aciduria and X-linked adrenoleukodystrophy. At least it will help in advising proper biochemical and genetic testing, further testing. It will actually narrow down the list of the differential diagnosis, and further testing can be done accordingly. I'm not able to go to the next slide.
Oh, please click on like enter button or the arrow marks button. Any arrow marks key? Arrow key.
Up, down, and both are not working actually.
Could you please try enter?
Yeah, it's working. Yeah. So we can classify these metabolic disorders, and there are various methods of classification. The classification methods can be based on either they can be classified on the basis of organ systems involved or cellular organelles which are involved, because basically these disorders are due to deficiencies also of some enzymes or some hormones or some at the genetic level basically. So according to the cellular organelles which are affected by the mutations, and that is another way of classifying these disorders. Then biochemical abnormalities, identifying the particular enzyme or the hormone which is deficient, that is another way. And then the way which is actually useful for a radiologist is the brain substance involvement method. That is, either they involve the brain matter. Actually, most of the metabolic brain disorders, they involve all the parts, that is gray matter as well as white matter. But depending on predominant involvement of these two types of brain matters, they can be classified as leukodystrophies. They involve mainly the white matter of the brain, and the disorders which come under this category are Alexander's disease, Vanderknapp disease, etc. Then poliodystrophies are the diseases which predominantly involve the gray matter. Mitochondrial disorders and organic acidopathies come under this category. Then pan-dystrophies are the diseases which involve both the gray and white matter almost equally. These include diseases like Kahneman's disease and Krabbe's disease. Then how do we decide that which organ or which organelle or which part of the brain as such will be involved? And this depends on and this can be judged on the basis of concept of selective vulnerability. There are some areas which are more vulnerable to damage as compared to the others. And what decides the selective vulnerability? Mainly the metabolic activity of the particular area, like specific energy and nutrient requirements of certain structures, myelinating gray matter, myelinating white matter, especially the white matter which is undergoing myelination, and the basal ganglia. They are metabolically very active, and that's why they are the first parts to show changes in these type of diseases. These are also vulnerable as a function of age. As the age increases, their functionality keeps on changing. Like the there are areas which are active at any particular age and then as the age increases, then the vulnerable areas also shift. Then cerebral, this is a rough list when which areas are vulnerable at which point of time. The cerebral white matter is vulnerable before 32nd week of gestation. Basal ganglia are more vulnerable during the last 3 gestational months and the first 3 years of the life due to high metabolic rate. Myelinating and myelinated white matter involvement is especially seen in neonatal maple syrup urine disease, because the myelinating white matter is more vulnerable to damage. Then homocysteine selectively destroys fibrillin, resulting in lens subluxation and is toxic to vascular endothelium, and due to which it leads to thrombus formation, both arterial as well as venous thrombosis. So these are the images of a patient with homocystinuria. Here we can see this is an image from the MR venography, and this is the superior sagittal sinus. This is the right transverse sinus, and we can see that the left transverse sinus and the left sigmoid sinus are totally blocked. And this is MR angiography. This is venography, and this is angiography. Here we can see that the left side of the circle of Willis is almost blocked. We see that left MC is not seen, then left posterior communicating artery and left PC are not seen. So here we can see there is thrombosis of both arterial as well as venous systems, and this is an image of the eye, and we can see the lens is subluxated inferomedially. So this is a patient of homocystinuria showing typical changes. Then MRI sequences which must be done in these type of patients. T1 weighted inversion recovery is better than the routine T1 weighted image, except for the detection of basal ganglia hyperintensity in hepatic encephalopathy, Krabbe disease, or GM2 gangliosidosis, where T1 is better than T1 weighted inversion recovery. T1 weighted inversion recovery is better because it shows better contrast between the gray and white matter. So even subtle problems are easily picked up on this image. And metabolic brain disorders are one such entity where it is better, and it is still better in developmental disorders like polymicrogyria, and those things are also better seen on T1 weighted inversion recovery rather than simple T1 weighted image. The enhancement is better appreciated on T1 weighted rather than T1 weighted inversion recovery. So the entities where there are only 2-3 entities in the panel of metabolic brain disorders where enhancement, contrast enhancement has a role. In those particular patients where there's suspicion of diseases like Alexander's disease or adrenoleukodystrophy, T1 weighted imaging should also be done because contrast is better seen on T1 weighted rather than T1 weighted inversion recovery. Then T1 weighted is recommended in children less than 12 months and T2 weighted for 12 to 18 months of age, because myelination is better seen on T1 weighted before 12 months and on T2 weighted in this 12 to 18 month age group. Then modular inversion recovery better delineates small lesions in brainstem and gray matter nuclei. T2 weighted FLAIR imaging differentiates cystic lesions from T2 hyperintense lesions in white matter. And T2 images are more sensitive than FLAIR for brainstem lesions. So these are some technical aspects which we should keep in mind while imaging these patients to have a better quality of images and have better sensitivity to pick up these changes. Then important structures to be analyzed. These are the structures. This is a list of structures in the white matter, and there's a list of structures in the gray matter which need particular attention in suspected cases of metabolic brain disorders. Cerebral white matter, the subcortical U fibers, extreme capsule, external capsule, internal capsule, metalloid laminae, corpus callosum, anterior commissure, mammillary bodies, central tegmental brainstem, and cerebellar white matter. And in cerebral cortex, it is gray matter, cerebral cortex, claustrum, cottage nucleus, putamen, globus pallidus. These are all part of basal ganglia. Then thalamus, subthalamic nucleus, red nucleus, substantia nigra, dentate nucleus, cerebellar cortex. We should always have a system of we should make a system how we take a look at these structures. First, we can have our own way, like one can go for white matter first or gray matter first, but we should ensure that this list is completed and we have a look at all these structures, because the pattern of involvement, they lead us to so many important differential diagnoses. Then what is the approach to read an MRI of suspected metabolic brain disorders? First and foremost thing is one should rule out the mimics of metabolic brain disorders like hypoxic ischemic encephalopathy, then torch infections, perinatal infections, as I already pointed out, then viral infections, post-viral demyelination, etc. First, they should be ruled out. based on the imaging findings and correlated with the history also, clinical examination also. Then look for myelination pattern. What the normal myelination, whether the myelination is normal, whether it's delayed, it's demyelination, dysmyelination. Then pattern recognition. Then symmetry of the lesions, whether they're symmetrical or asymmetrical, contrast enhancement is seen or not, whether there are associated malformations of the brain, or there is microcephaly or macrocephaly. So we have to pay heed to all these parameters, and if we approach methodically, we can actually give a fair idea about the differential diagnosis. This is just an example. This is a case of hypoxic ischemic encephalopathy, and this is a T1 weighted image. This is a CT image. Here we can see there is hyperintensity in bilateral thalami, ventrolateral thalami, and posterior aspect of the lentiform nucleus. So this is typical appearance of hypoxic ischemic encephalopathy. And here also we can see slight hyperdensity of bilateral thalami. And here we can, this is T1 weighted image again, and here we can see there is perisylvium hyperintensity on T1 weighted images and suggestive of mild claviosis. So this is typical of HIE, and obviously we have to correlate it with history. There will be history of delayed cry and difficult labor. So these type of things have to be correlated, because otherwise we can see hyperintensity on T1 weighted images as well as on hyperdensity on CT in thalami in cases of Krabbe's disease also. Then here the history and the clinical scenario that leads us to a particular diagnosis. This is a patient with findings of rubella showing periventricular T2 hyperintensities on FLAIR images. And this is a patient of ADAM, acute disseminated encephalomyelitis. We see that lesions are multiple, not showing any particular pattern. They are not symmetric either. And the patient had a history of fever 2 weeks before. So this is typical, history is typical, and the imaging is typical. And moreover, it is involving both the gray matter, deep gray matter nuclei, as well as a white matter. So this is typical of acute disseminated encephalomyelitis. So the normal myelination, what is a, sorry. So this is but it's very important. We should know how the myelination actually proceeds. What is the normal way of proceeding of the normal myelination? The myelination in a child proceeds from central to peripheral. That is, the periventricular areas are the first to myelinate, and then it proceeds peripherally. Then caudal to rostral means the parts which are towards the feet. They myelinate first, and then they proceed rostrally. Then dorsal to ventral, and first the sensory parts myelinates, and the part of the brain which controls sensory functions, they myelinate first, and then the motor parts myelinate. What are so these are the various structures which are which show myelination on T1 weighted images and T2 weighted images. Brainstem, cerebellum, posterior limb of internal capsule, optic tract, perirholentic areas. They are seen as myelinated. That is, they appear hyperintense on T1 weighted images in term infant, and on T2 weighted images they appear hypointense. The myelinated parts appear hyperintense on T1 and hypointense on T2 weighted images. So they appear in term infants. So anterior limb of internal capsule, we can see its myelination at 2 to 3 months on T1 weighted images, and on T2 weighted 7 to 11 months. So there is a lag of seeing the myelination on T2 weighted images. So that's why it is said that less than 12 months T1 weighted images preferred for seeing the myelination, and after 12 months, 12 to 18 months, T2 weighted images are preferred. So one should be conversant with the normal myelination pattern. Otherwise, we cannot pick up the delayed myelination or the abnormal myelination patterns. Then this is a slide showing just the normal progression of myelination on MRI from birth to birth, that is term infant, to 2 years of age on a T1 weighted sequence. This is a term infant showing myelination of the posterior limb of the internal capsule bilaterally, T1 weighted image, and the myelination appears as hyperintense typically. And this is a 4-month-old child. This is 6-month-old child. We can see the myelination is progressing from central to peripheral. And then this is 12 months old child, 1-year-old child, and the age of 2 years. Actually, the adult myelination pattern is achieved. So these are axial and coronal sequences demonstrating normal terminal zones of demyelination. It is very important to know about these terminal zones of demyelination, because sometimes they are confused with subcortical type of demyelination. see this area, these are terminal zones of myelination, and here we can see a little bit of hyperintensity in the subcortical area, in the area of U fibers. U fibers haven't formed very clearly. Here we can see this, but if this is seen after 2 years of age, then we call it as areas of subcortical demyelination, as is seen in L2-hydroxyglutaric aciduria. So it is important that we do not diagnose this entity before the age of 2 years, because what this can be a misleading thing, because we can erroneously label these terminal zones of myelination as pathological. So then H1 proton spectroscopy is another imaging modality which can help us in diagnosing these things, though not very useful, but in some particular things it can be really helpful. Like creatine deficiency disorder can be diagnosed only on proton spectroscopy, because in that particular disorder there won't be any creatine peak on the spectrum. So absolute and relative metabolite concentrations vary according to the age. This is another important point. We should, because we are dealing with the children, we should know which peak we are expected to see at which age group. Otherwise, there can be so many erroneous diagnoses based on spectroscopy. We have to be careful while interpreting MRIs of very young infants. Na is small while choline is more prominent in neonates. Otherwise, in adults, choline, if the choline is prominent, we think about demyelination or tumors or something like that. But in children, this is a normal finding in neonates. By 4 months of age, NAA becomes the most prominent peak. By 6 months of age, spectrum assumes adult appearance. And lactate may be seen in brain of premature infants and first couple of weeks in term infants. So these are some deviations in children, and they have to be kept in mind while interpreting the H1 or H1 proton spectroscopy data. So this is just a pictorial representation how the graphs are seen at various ages. This is a normal term neonate. This is the spectrum at TE of 270 milliseconds. That is a longer TE value. The spectroscopy data is taken at a TE of 270 milliseconds. This is a normal B is a normal preterm infant. This is an infant age 6 months, and this is an adult control. You can see this adult and infant of 6 months almost having the same type of spectrum. As I said, that the normal pattern is achieved by the age of 6 months in case of spectroscopy, and in case of myelination, the normal adult pattern is attained by the age of 2 years. And this is the same graph, but with a TE value of 40 milliseconds. Then pattern recognition is very important. Actually, we cannot diagnose these type of patients properly if we don't adopt a pattern recognition approach. And what is this pattern recognition approach? Actually, we have to see in cases of white matter, what we have to see is whether the demyelination or dysmyelination or the signal changes, they are progressing in the anterior posterior or posterior anterior direction. So we have to basically think of it as whether anterior posterior gradient or posterior anterior gradient. And how do we actually make out this thing? If the changes are more prominent anteriorly than posteriorly, then we call it as anterior posterior gradient, and vice versa. And an important clue in this is if the disease is really advanced and we cannot make out gradients properly, then look at the internal capsules. If the anterior limb is involved more, then this is anterior posterior gradient, and if the posterior limb is involved more, then that is posterior anterior gradient. Then whether it's centripetal or centrifugal, that is whether the subcortical U fibers are involved more or the periventricular white matter is involved more. Subcortical U fibers, they are involved in Canavan's disease, but not in metachromatic leukodystrophy. Actually, subcortical U fibers are commonly involved or prominently involved in diseases which are having centripetal progression pattern, because in centripetal progression, the destruction actually starts with the subcortical U fibers. Then we have to pay attention whether external extreme capsules are involved or not. They are involved in alto-hydroxyglutaric aciduria and fucocytosis, and they are also involved in Wilson's disease. Then mammillary bodies are involved in Wernicke's encephalopathy. So involvement of mammillary bodies and periaqueductal gray matter, dorsal columns, they point towards Wernicke's encephalopathy or maybe subacute combined degeneration. That is, we have to go for the vitamin B12 assay. And these type of entities are totally curable. So it's very important to have a proper approach, because it's not like it's a total junk thing. Some diseases are actually curable, very little, though very little. but in others we can actually make a lot of difference in quality of life. So you should always try to have some idea about what is happening and where we can actually intervene. Then corpus callosum is to be evaluated for signal and volume. It's very important for this thing. Uh, it can tell us about the possible progression gradient of environment of hemispheric white matter, like the diseases which are having anterior posterior gradient. In those particular diseases there will be more involvement of the genome of the corpus callosum, and the diseases which are having posterior anterior gradient will show more involvement of the splenium of the corpus callosum. So looking at the internal capsule, whether anterior limb is more involved or posterior limb, or the corpus callosum, whether genome is involved more or the splenium is involved more, these all give us an idea about the progression pattern, whether it's anterior posterior or posterior anterior gradient. Then central tegmental structure of bones are non-specific but are sensitive indicators for metabolic and neurodegenerative processes both. Antigroid pattern of demyelination along venues is seen in metachromatic leukodystrophy and Pelizaeus-Merzbacher disease. So these images show us some, they give us an idea about seeing the progression. This is a patient which is showing anterior posterior gradient. We can see a very prominent involvement of the anterior white matter in the frontal areas compared to the parieto-occipital areas. So this is clearly anterior posterior gradient, and here there is involvement of both external as well as extreme capsules, and the claustra actually is well seen in between. So this is an example of anterior posterior gradient of involvement. This is a diffusion weighted image showing involvement of the genome of the corpus callosum and not the splenium. So this is also showing anterior posterior gradient. This is a comparatively advanced case where it's difficult to make out it started from here or there. But if we see the internal capsule, we see the posterior limb is involved slightly more than the anterior limb on both the sides. So most likely this was a case of posterior anterior progression pattern. And here we can see the involvement of the corticospinal tracts in the brainstem. And this is a patient which is showing posterior anterior gradient. Here the posterior part, that is parietal portion, is showing more signal changes as compared to the frontal part. And also in this particular patient we are seeing centrifugal progression. Periventricular areas involved more and the U fibers are spared. Subcortical U fibers are spared. And in this particular patient we are also seeing centripetal progression. Here the U fibers are destroyed and the periventricular areas are involved, but not that much. So basically more involvement is from the periphery. So involvement is progressing from periphery to central, that is centripetal, anterior to anterior posterior gradient. And this particular patient, the gradient is posterior anterior and centrifugal, that is from center to the periphery. In this patient also we can see the involvement of the corticospinal tracts bilaterally. That was for the white matter. Now coming on to gray matter, what do we have to see in the gray matter? We have to see thin cortex is seen in GM2 gangliosidosis, Vanden Kanavan's disease. Cortical dysplasias are almost synonymous of Zellweger's disease, fumaric aciduria. So if and in Zellweger's disease, what do we see mostly? We find perisalient polymicrogyria, and if seen with this subpiles, then it is almost diagnosis of Zellweger's disease. Then claustra are spared in alto-hydroxyglutaric aciduria but are involved in Wilson's disease. Both these organic acidurias and Wilson's disease, they show giant panda face in the brainstem at the level of midbrain. So and both these show the involvement of external and extreme capsules. But what differentiates one from the other is involvement of the claustra. They are spared in alto-hydroxyglutaric aciduria but are involved in Wilson's disease. Then subthalamic nuclei involved in Kernicterus and Leeds disease. Giant panda face, and as I said, in Wilson's disease and glutaric aciduria type 1 both. Dentate nucleus involvement is seen in organic acidopathies and cerebrotendinous xanthomatosis. Basal signal changes in acute metabolic crisis, Kernicterus and Wilson's diseases. Basal ganglia swelling is seen in GM1 and GM2 gangliosidosis, and to some extent is also seen in Alexander's disease. The spinal cord involvement is seen in Krabbe's disease in the form of involvement of cauda equina. cauda equina nerve roots actually enhance in Krabbe's disease. So this is an image showing giant panda face. There is hyperintensity all around. These are red nuclei in the reticulum of the. This is a picture of glutaric aciduria type 1 showing hyperintensity in the basal ganglia, and diffusion weighted image of the same patient showing diffusion restriction. As I said, the basal ganglia are vulnerable structure because of higher metabolic rates, and this is typical. And in these type of patients, this type of signal changes in basal ganglia, they indicate metabolic crisis. The child is really, really sick and has to be taken care of and may go into the ICU or intensive care unit. And how do we actually have an idea that this is a patient of metabolic brain disorder and not due to hypoxia or maybe due to status epilepticus? This type of changes can also occur in status epilepticus. Here is a clue. We are seeing the small child having so much of brain atrophy, then the Selvin fissures are open. There's incomplete operculation, and we see some collections over here, subdural type of effusions, or maybe all subdural hematomas, and there is bilateral frontal and temporal atrophy. These findings are typical of glutaric aciduria. Now it's very important to identify it is this entity, because if we restrict tryptophan in the diet, then we can actually obviate 90% of the neurological damage. So if we cannot treat, at least we can intervene and prevent the neurological damage. It's very important to have some idea what is going on. And this is another patient having basal ganglia hyperintensity thalami. And this is a liver cirrhosis. Actually, it was a patient with, actually I don't remember. Yeah, sorry, it was a patient of Krabbe's disease. This is these are the exiting nerve roots which are showing enhancement on contrast study, and this is signal changes in the thalami, enhancing exiting nerve roots in the cauda equina. This was a patient of Tay-Sachs disease or GM2 gangliosidosis. We can see the basal ganglia are swollen. So swollen basal ganglia, very typical of gangliosidosis, and we can see the white matter changes and the comparative atrophy of the frontal areas. And this type of patients, one should always look in the eyes for the cherry red spots. They can help in the diagnosis. And this is another patient showing the tigroid appearance of the white matter. This is due to perivenular demyelination. So this type of pattern is seen either in metachromatic leukodystrophy or in Pelizaeus-Merzbacher disease. Then another systematic way to assess these patients is contrast enhancement. It is important in mainly in these three entities. One is adrenoleukodystrophy, Alexander's disease, and Krabbe's disease. In adrenoleukodystrophy, there is mainly a contrast enhancement that is seen in the at the interface of the normal and demyelinating white matter, and it is mainly in the anterior portions, because this in Alexander's disease, and this patient actually this disease shows anterior posterior progression. So accordingly, the contrast is also seen anteriorly initially, and then it can seen all over wherever the disease progresses. Adrenoleukodystrophy shows very typical type of contrast enhancement. One thing is appearance is very typical: posterior parietal white matter involved, periventricular involvement, splenium mostly involved, and there is a zone of active demyelination which shows contrast enhancement. So if we I'll show the images, and it is almost typical, and nobody can forget this appearance. Then Krabbe's disease, there is enhancement of the exiting nerve roots in Krabbe's disease, as I've already shown the image above. And these are some dysmorphic features which are associated with metabolic brain disorders, and these dysmorphic features, if seen, should prompt us to go further into the detail, and they may occur as such also without any association with the metabolic brain disorder. But once we should see this, we should try to rule out something additional, like bilateral pericylin polymicrogyria is seen in Zellweger's disease, and diffuse polymicrogyria and open operculus is seen in fumaric aciduria, pachygyria and glutaric aciduria type 2, and non-ketotic hyperglycemia. Carousel abnormalities can be seen in non-ketotic hyperglycemia, glutaric aciduria type 2, mucolipidosis type 4. And we have actually seen callosal abnormalities in vanishing white matter disease also in almost all the patients. Then disturbed operculation is seen in glutaric aciduria type 1, and Sherry1 malformation tethered cord is in ethyl malonic aciduria. So this is also a list of the abnormalities, basically developmental abnormalities it's seen. These disorders we should actually think of these disorders also. What I would say, like things like glutaric aciduria type 1, it's better to overdiagnose these patients and have a proper workup for these patients rather than missing the patients, because these type of entities, we can make a lot of difference by just obviating something in the food like tryptophan. So much of disability can actually be avoided. So it's better to err on the higher side. So this is a case of adrenoleukodystrophy contrast enhancement. This is T1 weighted image with contrast enhancement. We can clearly see this is the central zone of demyelination appearing hypointense. This is a peripheral active zone of demyelination which is showing enhancement. This peripheral garland-like enhancement posteriorly is very typical of adrenoleukodystrophy. And this is the coronal image, T1 weighted contrast image is showing the same appearance. Central demyelination, hypointensity, and the peripheral zone of active demyelination is showing contrast enhancement here also, and we can see some hypointensity here also. So there is an outer zone also. This again, I think the same image of the patient with T1 hydroxy glutaric aciduria type 1 having basal ganglia hyperintensity, and same patient basically, two patients with glutaric aciduria type 1 with metabolic crisis. And so clinically, things also help us, like microcephaly is seen in Zellweger's disease, Aicardi-Goutieres syndrome, Cockayne's disease, Pelizaeus-Merzbacher disease. Microcephaly is seen in Vantanav, Canavan, Alexander type 1 glutaric aciduria, L2-hydroxyglutaric aciduria, GM2 gangliosidosis, vanishing white matter, and mucolipidosis. So all the parameters we have to keep in mind. Then this is the list of disorders which have almost pathognomonic MRI patterns, and we can almost give a confident diagnosis. These are L2-hydroxyglutaric aciduria, glutaric aciduria type 1, neonatal maple syrup urine disease, Zellweger disease, X-linked adrenoleukodystrophy, Canavan's disease, Alexander disease, Vantanav, leukodystrophy with brainstem and spinal cord involvement and highlighted, and mucolipidosis. So this is a patient with L2-hydroxyglutaric aciduria. She was a 2-year-old female with delayed development. Here we can see very clear anterior-posterior gradient, and these are the normal U fibers, and here we can see very clear-cut destruction of the U fibers. Because this is a 2-year-old female, so this cannot be terminal zone of myelination, and it's very clear that it's anterior-posterior, and it's basically centripetal progression from periphery towards progressing towards central, periphery to central, periphery to central. Here periventricular areas are not that much involved. The main involvement is of the peripheral areas. Here also we can see the same pattern, and on spectroscopy all the peaks are reduced. So this is typical appearance of multiple areas of hyperintensity in the subcortical areas, very typical of L2-hydroxyglutaric aciduria. And very important point about L2-hydroxyglutaric aciduria is that the child shows more, MRI is very drastic, but clinically the child is almost normal and shows delayed development and all those things. Their clinical symptoms are mild and they start at a later age. So MRI is more drastic, while clinically the child is comparatively well. So here this is 2.5-year-old male. I had shown you a previous figure where this type of appearance was shown as a normal terminal zone of myelination, but at 2.5 years, this is not normal zone of terminal myelination. This is normal myelination, which is actually progressed up to almost tip. Here, there is destruction of this myelination. So this is typical destruction of the cortical U fiber. So this is a very early case where the destruction has just started. And this is another entity which is almost pathognomonic, that is glutaric aciduria type 1, 1.5-year-old male child. So we can see there is severe atrophy of the frontal lobes and some atrophy of the temporal areas also. There is incomplete operculation, comparatively open sylvian fissures bilaterally, and we can see the subdural hematomas of different ages. Here we can see this is subdural hematoma, another subdural hematoma. So when we see subdural hematomas, one thing is child abuse, battered baby syndrome. So, but it is also seen in glutaric aciduria and another metabolic disease where we can see this subdural hematoma, this Menkes-Genki-Hair syndrome, because in those particular diseases, the collagen is defective, and so bleeding is very common. This is the same child, and here what we are trying to show is basal ganglia hyperintensity. This image is, I think, coming quite a lot because this is showing the child is in metabolic crisis. Then another patient with glutaric aciduria type 1. This is comparatively advanced case. You can see we cannot make out much on this image, but yes, here this is T1 weighted image. We can see the basal ganglia comparatively hypointense. And this is giant panda face of the glutaric aciduria, this one. And these are the red nuclei. This is the surrounding area of the brain, of the midbrain, showing T2 hyperintensity. So if we see the spectroscopy, there's a little bit of lactate over here, but otherwise the spectrum is not very abnormal. So this is slightly advanced case, but with metabolic crisis. This is a typical adrenoleukodystrophy, posterior involvement, centrifugal involvement. It starts from periventricularly and then progresses peripherally. And the splenium of corpus callosum is also involved. Here we can see there is enhancement of the transitional zone of demyelination, coronal eggshell and coronal images. So, see, it's very important in this particular case. What is very important is we can see the progression of the disease from the outer zone to the intermediate to the inner zone. This is the spectroscopy pattern of the outer zone. This is the intermediate zone. This is the inner zone. The inner zone is the first to have demyelination, and when the demyelination actually progresses centrifugally, the inner zone is almost burnt out. So here we can see choline is so big. Then this is a small Na, and this is lactate. And what, no, sorry, this is creatinine and this is Na. Actually, this is choline, this is creatine, and this is Na. So here you can see this is such a big choline peak, such a small Na peak. This is intermediate zone. Here choline is big, but Na is not that small. And in the outer zone, we can see the Na is comparatively big. Choline is more than the creatinine, but still smaller than the Na. So we can make out we can see the reversal of the peaks. Here the Na is normal, and normal, it's not actually normal, it's slightly reduced, but we cannot make out how much it is reduced. But it is still more than choline. Here it's less than choline, it's drastically less than choline. So this spectroscopy at various zones is showing the gradient very nicely, and how the destruction pattern actually propagates. The Vanderlap disease, this is a 7-year male child. It is mostly seen in Agarwal community in India. And very typical of this is it is having anterior posterior gradient again. And what is typical of this is subcortical cyst formation. We can see, and mostly these are seen in the frontal and temporal area. So this appearance is almost diagnostic of Vanderlap disease. And this is a child with Hurler syndrome. Here we can see there is a centrifugal type of pattern. Periventricular area is more and more. U fibers are comparatively spared at this stage also, and posterior anterior gradient. And what is very important of this is these spaces, perivascular spaces involved, mucoid degeneration of these perivascular spaces. And we can see bullet-shaped vertebra, low vertebra, and this basically CV junction narrowing. And so this is typical of Hurler syndrome. The patient had white cornea, that white reflects through the cornea also. Those were the diseases previously we discussed. They were MRI is almost diagnostic. And this is a list of the diseases where MRI patterns are suggestive but not diagnostic. But once these patterns are suggestive, it definitely narrows down the list of differentials, and it guides the further genetic or biochemical testing. These are methylmalonic aciduria, 3-methylglutaconic aciduria, beta ketothiolase deficiency, late onset form of maple syrup urine disease, homocystinuria, Krabbe's disease, metachromatic leukodystrophy, and GM2 gangliosidosis, vanishing white matter disease, Leak's disease, Menkes disease, and Wilson's disease. We'll see some of these entities. I've shown this picture before also. This picture, this is a case of homocystinuria. This is MR venography showing obliteration of left transverse and sigmoid sinuses by thrombus. Here the left side of the circle of Willis, left PCA, left posterior communicating artery, left MC are almost blocked. And secondary to this, we see there is old infarcts and gliosis and encephalomalacia in the left cerebral hemisphere. The same is seen on this T2 weighted image, and there is inferior medial subluxation of the lens. So this is a typical case of homocystinuria. Then this is a patient with Krabbe's disease. This is a CT image showing hyperdense bilateral thalami. This is an MR image. It's a slightly advanced case, and here we can see there is atrophy of the brain, and white matter is almost atrophic. and there is enhancement of the exiting nerve roots in the corda equina. So, and on T2 weighted image, we see there is hypointensity in bilateral thalami. So this is typical of Krabbe's disease. And Krabbe's disease is one disease which is having centrifugal pattern of demyelination and posterior anterior gradient. It's not very well seen on this case because this is a comparatively advanced case and a burnt out case. This is a patient of metachromatic leukodystrophy. Here we can see the trigoid pattern of demyelination in the bilateral centrum semi-ovale, and there is a diffusion restriction in genome as well as splenium of the corpus callosum. So here it's difficult to make out the gradient, whether it's anterior, posterior, anterior. But metachromatic leukodystrophy normally has posterior, anterior gradient. And here also we can see the trigoid pattern on T1 weighted images actually. This is another patient with metachromatic leukodystrophy. So this is to show that sometimes the changes are not very symmetric, and it's you can see the asymmetry. There are some signal changes over here, but on the left side it has progressed so much, and on the right side it's just starting from the, but see, this is important because it is telling us where it is starting from. It is starting from posterior because the anterior side is not showing so much of signal, very little, or you can say almost normal, and it has started periventricularly. The fibers are nicely spared, so this is showing the centrifugal as well as posterior anterior gradient, and here it's progressed, comparatively progressed on this side also. And this is there are signal changes in the brainstem also. This is a patient of GM2 gangliosidosis. This was a 7-month-old female. It was diagnosed with T6 disease. We got the very important thing about this is basal ganglia is so much swollen. See, the basal ganglia is swollen and thalami are comparatively atrophic, and we can see the signal changes in the white matter and bilateral frontal areas. And this is a T1 weighted images. We can see the hyperintensity in the thalami and the swollen basal ganglia. So the clue to diagnosis in this particular patient was swollen basal ganglia, and when the eye examination was done, we could see the cherry red spots also. This was a case of Wilson's disease. This is typical giant panda face, red nuclei in the background of T2 hyperintensity in the surrounding tissues. And then here, this is the sign I was talking about, that the involvement of claustra is diagnostic of Wilson's disease, because giant panda face is seen in glutaric aciduria 1 and also in alpha-hydroxyglutaric acid, means organic aciduria can also show this giant panda sign. But involvement of claustra is seen in Wilson's disease, and this actually differentiates from the organic acidurias. And this is a section slightly higher up showing anterior, posterior, and centripetal gradient. This is ultrasound scan of the liver showing liver cirrhosis, which is very common in Wilson's disease due to copper deficiency. This is an eye image showing a Kesher Fletcher ring. This thing. So this is a typical case of Wilson's disease. Another patient with Wilson's disease with giant panda face and cavitation of the claustra. So typical findings. See here, the basal ganglia have so much atrophied. Actually, they have gone up to almost cavitation, and you can see the size of the choroid nuclei and the ballooning of the frontal horns because of this atrophy of the basal ganglia. There is ex-vacuo dilatation of the frontal horns of bilateral lateral ventricles, and these are white matter changes. So this was the patient, another patient of Wilson's disease. This is the patient with vanishing white matter disease. The very typical finding about vanishing white matter disease is the cavitation of the white matter, and that is in line with the angles of the ventricles. You can see these cavities. These are in line with the frontal horns, and this cavitation is in line with the occipital horns of the lateral ventricles. So this finding is very much typical of vanishing white matter disease. And here on T2 weighted images, you can see this cavitation, and here it's there. Here they are in the line with the ventricles, and here also they're in line with the ventricles. And on MR spectroscopy, we see there is blunting of almost all the peaks because the white matter is actually vanishing. This is methylmalonic aciduria. The typical thing is there's hyperintensity in the bilateral global pallidi, and the lentiform nuclei are spared. And we see T2 hyperintensity and T1 hypointensity. But as the cavitation, as the disease progresses, there may be cavitation, and accordingly we can see the signal changes more prominently. So these changes actually have to be differentiated with kernicterus, because in kernicterus there can be T1 hyperintensity. So signal changes are almost in the same area, carbon monoxide poisoning and kernicterus can be good differentials, and they have to be kept in mind, and we have to make a diagnosis keeping in mind the history and the clinical presentation. Then this is again methylmalonic aciduria. Here we can very nicely see the changes in the global pallidi. and medullary lamina are actually highlighting the changes. You can see in both parts of the globi pallidi, both outer and inner compartments are showing signal changes, and diffusion restriction again in the globi pallidi only. So this is a very clear-cut case of methylmalonic aciduria. Then this is a patient of Leak's disease, and we can see the changes in the dentate nuclei. In addition to the white matter, changes are seen in the dentate nuclei, dentate nuclei, and in the corticospinal tracts. And here, what was important was there was lactate peak. So it was pointing towards mitochondrial disorder or oxygen, basically oxidation disorders. And so mitochondrial disorder, this was a clue, and the findings were also typical. This is another patient showing so much signal change on T2 weighted images, paraventricular, mainly anteroposterior, and all this area is showing diffusion restriction. So it's very important. Once this much diffusion restriction is seen, we should always put on a spectroscopy on this, and there was a very large lactate peak in this. So our clinician was actually thinking of this patient as vanishing white matter disease, but we gave it as a mitochondrial brain disorder. And on genetic testing, actually it turned out to be cystic leukoencephalopathy in NDUF1 mutation, and it was actually published in this Indian Journal of Pediatrics. So sometimes we can lead clinician. This is vacuolating myelopathies. Once we see vacuolating encephalomyelopathies, we should always think of mitochondrial brain disorder. So in these type of patients, always put a spectroscopy on, because mostly we see a lactate peak in these mitochondrial disorders. Vacuolating myelopathies, put a spectroscopy on, and mostly we see this. If we see the lactate peak, then mitochondrial disorders are the first ones to be ruled out. This was a child with Menkes disease, Menkes kinky hair. You can see the hair are fragile and they lack pigment, very dry type of hair. And here we can see that the vessels are showing tortuosity, kinky vessels. And what we see on diffusion weighted imaging is the areas of diffusion restriction. These are due to thrombosis, because these vessels, they also have tendency to thrombose. So this was a typical case of Menkes kinky hair. It was diagnosed prospectively, not retrospectively, on MR only. And these patients can also show various stages of subdural hematomas. So two entities basically show subdural hematomas in metabolic brain disorders, neurogenic aciduria type 1 and Menkes kinky hair disease. So this is actually how the proper approach helps in reaching a proper definition. This was the patient. It's a MR angio of the same patient, this patient only. And here you can see the tortuosity of the vessels. That's why we call it kinky hairs. Menkes kinky hair are kinky, and the vessels are also kinky because of collagen disorder defects. And diffusion weighted imaging can also help to some extent. Like cytotoxic and myelin edema show restricted diffusion, while vasogenic and interstitial edema, they do not show increased diffusion. It is not possible to differentiate these type of edema on T1 and T2 weighted images. So diffusion weighted images enhance specificity in differentiating these four types. Actually, two, cytotoxic and myelin edema, they show restricted diffusion, and vasogenic and interstitial edema do not show restricted diffusion. So actually, one disease which actually can be diagnosed based on this only is maple syrup urine disease, neonatal maple syrup urine disease, because that is showing myelin edema. And there's typical appearance on diffusion weighted images. The myelinating white matter in the posterior fossa may show diffusion restriction that is almost diagnostic in the background of a child having smelly urine. Then cytotoxic edema is seen in acute gray matter diseases. Myelin edema is seen in active demyelination, as I said in maple syrup urine disease. In fact, we diagnose neonatal maple syrup disease based on restricted diffusion only. Then vasogenic edema may be seen in metabolic crisis. Acute involvement of deep gray matter structures and organic astropathia and mitochondrial disorders is more conspicuous on diffusion weighted images. That is, the child is in metabolic crisis. That is more perceptible on diffusion weighted images. And diffusion weighted images helps in monitoring of disease progression and differentiating between active and burnout phase of diseases in some cases particularly. And so in adenoleukodystrophy, the actively demyelinating zone shows contrast enhancement, but we have also seen diffusion restriction only in that actively demyelinating zone, that is the intermediate zone in X-linked adrenoleukodystrophy. So that's how things can help. This was the case of maple syrup urine disease. We can see that the areas these are the areas which are showing myelin edema and showing diffusion restriction. So this type of appearance in the posterior fossa cerebellum in the brainstem, almost in a small child with mental retardation, smelly urine, almost typical and almost diagnostic of maple syrup urine disease. Here we can see the branch chain ketotic acids on MR spectroscopy at 0.9 ppm. So this was again somehow the patient with glutaric aciduria type 1 only in metabolic crisis. I think this is a patient with the mitochondrial brain disorder. Here we can see there is vacuolating myelopathy with areas of diffusion restriction. So it was actually supposed to be a quiz, actually, I think. Then proton MRSR, proton spectroscopy. What are the technical aspects? The important points while taking the spectroscopy is the voxel size should be preferably 2 by 2 by 2 centimeter or larger. Smaller size than this can actually lead to problems because of partial volume effect due to overlying structures. Then calcified hemorrhagic or cystic necrotic areas should be avoided while placing the voxel. Short echo time 20 to 30 milliseconds. It is helpful in picking up myoinositol peak, glutamate, glutamine complex, branch chain amino acids. Actually, branch chain amino acids is seen in maple syrup urine disease. Glycine is best seen in 135 milliseconds. Intermediate echo time. It overlaps with that is myoinositol at 3.55 ppm on short echo time spectra. And lactate shows well-known J coupling phenomena. It is negative doublet peak at 135 milliseconds, positive peak doublet at 270 milliseconds. So it is also very important that which disease we are reading and which disease we are actually suspecting, and why we are putting the spectroscopy on a particular patient. We should know what we are suspecting and which peak we want to elicit. Like if we want to elicit this glutamate complex or myoinositol, then we have to use short echo time. And if we want to see glycine, we have to use intermediate echo time. For lactate, we have to use both the intermediate and long echo time. So it depends on which entity we are trying to make out, and accordingly we have to technically select which type of spectroscopy we are doing, and at what TE value we are doing the spectroscopy. This is just a list of metabolites seen at various positions, at what ppm the metabolites are seen. And this is abnormal spectra. Lactate is seen in mitochondrial brain disorders, systemic lactic acidosis, metabolic crisis of inborn errors of metabolism. All the patients in metabolic crisis may show lactate peak, hyperperfusion, inflammation. Glutamate are seen in urea cycle defects, propionic acidemia, hepatic encephalopathy, hypoxic ischemic encephalopathy. Increased NA is seen in Canavan's disease. Canavan's disease can be diagnosed only on spectroscopy. There are two metabolic brain disorders which can exclusively be diagnosed on spectroscopy. These are Canavan's disease, which shows increased NA peak, very highly increased NA peak. And another thing is creatine deficiency, where we do not see any creatine peak on spectroscopy. So spectro is diagnostic in these two diseases, Canavan's disease and creatine deficiency. Absence of creatine. So in this, we don't see the creatine peak. So in the same patient. Then clinical criteria are equally important in assessing these patients. Age of onset is important. Some entities have very early age of onset, like GM2 gangliosidosis, Tay-Sachs disease, very early onset, perinatal onset. Vanishing white matter disease, late onset. So age of onset of the symptoms, they give us a very broad idea. Then systemic manifestations. What are the other systemic manifestations, like like cirrhosis, liver cirrhosis seen in Wilson's disease, copper metabolism disorders. Then here, as I showed, the lustrel is hyperpigmented, fragile hair are seen in Menkes skincare syndrome. So we have to see the patient as a whole, and the systemic examination is very important because it also gives clue to some diagnosis. And either the child is having macrocephaly or microcephaly, neurological presentation, whether seizures, pyramidal or extrapyramidal signs, and then visual disturbances are there or not, tone abnormalities, peripheral neuropathies, psychiatric manifestations, order like maple syrup urine disease, and then faces, which type of faces the child is having, is an instant skin stigmata. ophthalmological abnormalities like the lens subluxations and all those things. Then biochemical investigations are important. Then hyperammonemia it can be normal or borderline elevated in maple syrup urine disease, urea cycle defects and organic acidemias, but blood pH shows respiratory alkalosis in urea cycle defects and metabolic acidosis and organic acidemias. See how important it is. It can be borderline elevated in both organic acidemias and urea cycle. But see, urea cycle disorder, it shows blood pH shows respiratory alkalosis, while in organic acidosis it is metabolic acidosis. So these fine points, they do help us reach somewhere. Coupled with MRI, it's very we can actually either diagnose it properly, or we can at least broadly categorize it into, like, if not glutaric aciduria type 1, we can see it's organic acidemias. So it helps a lot in managing the patient, preventing neurological damage, or managing or providing supportive care or treatment, whatever is available. Definitely we can add something to improve the quality of the life. Then metabolic acidosis with hypoglycemia, normoglycemia with or without lactoacidosis, ketoacidosis, hypoglycemia with or without ketosis, liver function tests, all these help, coupled with MR findings, help in reaching a particular diagnosis. Hypoglycemia is never seen in beta ketothiolase deficiency, 4-hydroxybutyric later onset 3-methylglutanic aciduria, biotinidase deficiency, glutaric aciduria type 1, late onset form of maple syrup urine disease. And advanced laboratory methods can be used to further refine the diagnosis. That is gas chromatography and mass spectroscopy of urine, high pressure liquid chromatography, tandem mass spectroscopy is almost standard of care these days for diagnosing. This test actually diagnoses a wide range of, it's just a test based on blood sample, and it diagnoses a wide range of metabolic disorders. The specific enzyme activity studies of fibroblast, peripheral blood cell culture, or biopsy specimen can be done. Histological diagnosis, peripheral nerve biopsies can help in MLD, mitochondrial leukodystrophy or Krabbe's disease. If the MR pattern is suggestive, then one can go for peripheral nerve biopsies straightforward. So in this way, MRI can actually guide further investigations. Then muscle biopsies can be done in mitochondrial disorders. Skin, mucosa, or liver biopsies in storage disorders, Wilson's disease, brain biopsy autopsy in Alexander's disease. So treatment, we're not actually dealing with the treatment, but this slide is important because neonatal some diseases, it is just a glimpse of why it is important to still categorize these diseases and to reach some conclusion, because even if they're not totally treatable, but we can actually make a lot of difference. The neonatal peroxisomal disease, severe forms of propionic acidemia, maple syrup urine disease, pyruvate dehydrogenase, and cytochrome C oxidase deficiencies are incompatible with life and lead to early death. Dietary control can help, like obviation of tryptophan in glutaric aciduria type 1. Wilson's disease, naturally mild and riboflavin dependent forms of glutaric aciduria type 1, phenylketonuria, 3-phosphoglycerate dehydrogenase deficiency, guanidoacetate methyl transferase deficiency, they respond well to treatment. Then bone marrow transplantation can be done in MLD and Krabbe's disease. Enzyme substitution can be done for some disorders. Organ transplantation to manage systemic complications of some metabolic diseases, Wilson's disease or methylmalonic aciduria. Then emergency techniques, somatic gene therapy and fetal neonatal transplants can be done. So these are some are experimental, some are in the clinical domain, but at least there some direction can be given to the patient. Then this should be the reporting format for MRI in cases of metabolic brain disorders. First, we should tell about myelination, whether it's normal, delayed, demyelination, dysmyelination, signal abnormalities involving gray matter, white matter, both symmetric, asymmetric, patchy, or confluent, pattern recognition, anterior, posterior, posterior, anterior gradient, centripetal or centrifugal gradient, basal ganglia status, external extreme capsules, cerebellum, brainstem, diffusion characteristics, spectral findings, contrast if needed, and narrow down the differential to 3 to 4 entities and as biochemical or genetic investigations accordingly. This is a galaxy of metabolic brain disorders at our institute. So this is a list of the disorders which we have seen in the last 3-4 years. The take-home messages: inborn errors of metabolism are not so rare. Actually, they are either not diagnosed or misdiagnosed. So many cases of metabolic brain disorders are erroneously labeled as hypoxic ischemic encephalopathy or perinatal infectious disorders. So it is important to diagnose them early for both management in the form of dietary control, chelating agents, enzyme substitution, bone marrow organ transplantation, somatic gene therapy or fetal neuronal transplant, and genetic counseling of parents for future pregnancies. It is very important to know the pattern of myelination in normal infants and children. Important to differentiate inborn errors of metabolism from hypoxic encephalopathy, which is common confounder both clinically as well as radiologically. And I thank you for your patient hearing. Hello?
Yeah, yes, Dr. Seema. So yeah, do we have any? Yeah, you were audible. So yeah, do we have any comments or any questions for Dr. Seema? So do we have any questions? I guess there are no questions. So yeah, thanks a lot for your presentation, Dr. Seema. It was informative. And yeah. So moving on to our next presentation, it's from Dr. Maria Dalamaka, and that's from General Hospital of Larissa, Greece. And being in an ICU situation right now, she's unable to attend the webinar, and yeah, we are going to skip her topic. So yeah, for the next presentation, we have from Dr. Gosta Alphaven and Eva Andersson from Karolinska Institute, Sweden. So for this, we're having a video presentation. So yeah, I'll just play the video right now.
Hello, yes, thank you. I'm trying to turn on camera. Here we are. Hello, nice to be joining this seminar. And I will show you a video presentation that Eva Andersson, an associate professor in Stockholm, and I have produced together. It's work since many years, and the focus in this presentation is an EMG study that shows the importance of the startle reflex in stress and pain. And now I hope that the presentation will come along, and here we are, I think. So it
Yeah.
will start immediately. Thank you for the invitation.
Doctor, please click on the screen button so that you'll be able to share your screen with us.
My name is Eva Andersson, and I'm a medical doctor and a physical education teacher. And I did my PhD with the method electromyography, and I've been working with that method for about 30 years.
And my name is Gösta Alvén, and I'm a pediatrician, and I have been interested in
Dr.
pain.
Gosta Alphaven, I'm sorry, but the video is not displayed. So please click on the screen button to show us your screen.
It's not shown.
No, the video is not shown to us. Please click on the screen button
In recurrent pain, in muscle
present at the
tension.
bottom, like the mic, camera, screen, and leave. So over there, please click on the screen button.
Airplay, is that the one? Stress and somatic symptoms.
Please pause that video for a moment. I'll just explain you how to continue.
Thank
So
you
once
for the I paused it for us to come here and give.
Yeah. Now coming back to the GoToMeetings app, click on the screen button.
Give a speech. No, I don't know what to do. Sorry.
My name
Okay,
is Eva
it's okay.
You can't see it?
And
No, I can't see it. So what we can do is I have the video link with me. I'll play the video from my side. You can just stop
Okay,
the
that's fine.
audio. Yeah, I'll just do that from my side.
I'll stop. Do you show it from your?
Yeah, I'll do that.
Oh, that's fine. I don't understand what happened, but if you do it, I'm happy and glad. Yes.
I hope you can see the screen.
I can see it. Very nice.
So yeah, just give me like please let me know if the audio is also clear from our side. One moment. Just give me a moment.
Yes. Do you find the audio?
So is the audio clear, or is the audio audible to all?
I can't hear anything.
Is that good now? Like, can you hear?
I hear it in the background, but it's very weak.
Okay.
I can tell you, it's a study of children, teenagers mainly, and we will present some data concerning stress and pain and how that is established and shown in the body with muscular tension and pain that comes from these tensions. And we also present some data concerning the bicameral brain, that is the right side that is active during stress, as you may know. And we have some hormone data that support this. Okay, do you get the no, we can't hear anything.
Okay, then I guess you'll have to do that from your side. Let me just explain you. I guess on the screen you will find the buttons, 4 buttons at the bottom. Could you please see the mic, camera?
I have to okay, I have to open my
GoToMeetings app.
yes, I have open system preference. I don't know if that's what I should do.
Okay, you will have to give the permissions for GoToMeetings to access your system. So please click on OK or
and now,
thank you for the invitation for us to come here.
Only the audio is being.
And I will do that together with.
Do you hear it?
On the video.
And I'm a medical doctor and a physical education teacher.
The video is not displayed. For that, you will have to share your screen with us.
Yes, okay.
You have the 4 options over here: mic, camera, screen, and leave at the bottom.
Yes, I tried to do that, and
click on screen.
Today we present an increased understanding
why
of
isn't
an important defense reflex.
I think I have to start from the now I'm here, and I have to camera screen. Yes, I have screen.
Yeah, click on that.
Open system, and it's not opening.
Like you'll get a pop-up showing you all the windows that is being opened. So click on the video so that your screen will be displayed to us.
Yes. Restart GoToMeeting. I have to restart. Okay. So I restart, go to meeting, and that's here we are now.
That.
Yes, and I think it's going okay. And I open the screen, and oh, it's very strange.
Is that
Open.
not?
No, it's very strange.
Does that allow you to do that?
No, the screen is not opening.
Oh my God.
I've tried
Okay.
several times now.
Just let me try from my side if I can play the video with the. Yeah. No, not this. One moment.
Very strange. What we showed, we made an EMG study. Okay, here it is. Can you get the loud, the voice? And we compared children in chronic pain of psychosomatic origin with
Eva Anderson. And
Was that audible now?
Yes.
So can I play the video? So is it audible?
Yes. Do that. Thank you for the invitation for us to come here and give a speech. And I will do that together with.
my name is Eva Anderson, and I'm a medical doctor and a physical education teacher. And I did my PhD with the method electromyography, and I've been working with that method for about 30 years.
And my name is Gösta Alveni, and I'm a pediatrician, and I've been interested in pain and stress since several decades. And today we will present an increased understanding of an important defense reflex, the startle reflex. It's of importance in stress, in recurrent pain, in muscle tension. We will use the word psychosomatic for the reaction of stress and somatic symptoms to give the important aspect of the neurobiological context. It's important to have in mind that stress is a general reaction. It includes many different aspects of the body and the brain. And as you can see on this picture, it's a girl, 6-year-old, with psychosomatic pain since half a year, from headache, from the stomach, and also some other areas, and with other psychosomatic symptoms. Look at her, and you will see the general muscular reaction that is involving her. Her head, look at the head, it's tilted forward. Look at the shoulder, they are tilted forward. The chest is in increased kyphosis, and the lumbar region is in increased lordosis. And you can see the tensions in legs and arms. So this is a muscular, a neuromuscular reaction. And what is the cause of it? That's the main point in our presentation. And of course, a lot of other things happening in the body of long-standing stress, and she will have a lot of other symptoms, nausea, loss of appetite, etc. And I show you the abundance of different symptoms that a girl or a boy or a grown-up can have in a long-standing stress. Today, we know that stress can cause different symptoms. That has been a long discussion of this matter for decades. But the
epidemiological and the clinical and the neurobiological evidence for such a connection is now clear. And this first picture concerning recurrent pain shows the abundance of recurrent headache. In girls, it's very common. It's a WHO study from Sweden, and you see that almost a third of teenagers are suffering from headache at least once a week. Stomachache is also common, and other pains are also frequent. And the epidemiological data that the connection between stress and pain. I'll show you two pictures of that. The first one is from Utøya. You know, I think about the terror attack that happened a few years ago, and almost 100 youngsters were killed, and those who survived, of course, suffered from psychosomatic pain problems. And as you can see, more than a triple of tension headache you found in the teenagers that had suffered from the terror attack. This picture is the one above is about boys, and the low one is about girls, and the ordinata is the frequency of pain, and the abscissa is the frequency of perceived stress. And as you can see, the frequency of headache and stomachache increases dramatically with increased perceived stress. So if you have perceived stress every day, you will have recurrent pain in 60% of the boys and in 80% of the girls. That's the black bar. And the gray bar, the second to the right, it's the co-occurrence of pain. And as you see, that also increases with increased pain. And that's so typical for stress. The general reaction is broadened, and you get, with more stress, more pains. And this picture wants to show what happens when a boy or a girl is threatened and get into stress. The major stress area is the amygdala. That is well known. It's an emotional and a center where stress is an important reaction. And the stress starts reactions in different body organs and brain areas, and it will give rise to a lot of different symptoms, including headache and other pains. I want to show you two pictures concerning more data about the body reactions. This is a picture of youngsters, 10 to 12 years old, that is telling, they are drawing their stress, where they feel their stress. And as you can see, it's in the head, in the temporal regions, in the occipital regions, in the trapezius region, in the breast, and in the stomach. And that's where they have drawn their feeling. But I think you can see it's the same areas as you will find the recurrent pain, the recurrent headache, shoulder pains, breast pains, and stomach pains. So the feeling of stress is situated at the same place where they will find the where they will have the pains. And this is another picture of how stress and recurrent pain is manifested. It's what I call stress tender point pattern, and you need to be rather skilled to press with the right pressure. But if you do that, you would rather find rather easily find these tender points, and they are in the region of the temporal region, the occipital, the trapezius, and the stomach, and in the breast. And as you see, it's the same areas where you have the feeling of stress and recurrent pain. It is important, and I underline that you get a firm diagnosis of psychosomatic pain when stress is giving starts pains. And I have elaborated 7 criteria. The 5 first are validation, and the two last is the reliability. And I'll shortly tell you about these 7. It's you have to find that stress starts. You have stress when the pain stops. You have stress in parallel with the pain. You have diminished or vanish of the pain attacks when the stress diminishes or vanish. You have acute stress eliciting pain at least in 5 of 10 pain occasions. And you have to follow, the same doctor has to follow the patient and the family for a longer time to get reliable data. And you have to be in agreement in the end about the diagnosis. Otherwise, there is some information difficulties. So these 7 criteria were used in the study that Eva Andersson now will present. 19 children we caught in the study, fulfilling at least 6 of these 7 criteria. So that's enough for a diagnosis. And they were matched to a control group. So now I give the word to Eva Andersson. Thank you.
Yes, Gösta Alvén and I and Sten Grillner made a study when we registered muscle activity in the startle reflex. And as you can see in the picture, it starts with the blink reflex, and it's followed by the head bending forward and a descending bending reaction of the body, which is spread down to the legs. You can also see in the lower part those muscles we measured and the abbreviations for them. It was OR, orbicularis oculi, TE temporalis muscle, which is here, and trapezius, TR, pectoralis, PE, rectus abdominis, RA, and erectus spinae at the lumbar region. And these spots are similar to the tender points as I just told you just before. And we measured EMG when the activity rise about 10 microvolts. Then we had the onset you see to the left of the pictures. And when it decreased to below 10 microvolts, it was the offset. And in the middle, you have the peak, which is only measured for 1 millisecond. And to the right, you can see the EMG signals for those muscles I just mentioned. And to the left there, you have a small blue line thin, which shows where the sound began. And in addition to the peak, we also measured mean EMG amplitude. And then we had that for the whole burst. You can see in the lower part of the picture to the left, from the onset to the offset. And we also measured during 200 milliseconds from the onset of the orbicularis oculi. And we had some other time intervals as well. We will show you the results for those 19 children who had recurrent stress-related pain in the head and in the neck and in the abdomen. We call that group pain, and it's diagnosed according to those strict defined criteria you just have heard about. And we had a control material, and we call them healthy. What's 23 healthy controls, and the age for those two groups were 10 to 17 with a mean around 13 years. And the start reflex was triggered by repeated strong audio signals, 105 decibel, 50 milliseconds duration stimulus of uninspected short white noise. And that was through the headphones in supine position and during calm and equivalent situations. And we measured the muscle response and did then the analysis for these sudden signals with mean of a total of 8 acoustic signals together. And those 8 signals were given with intervals between 1.5 to 2 minutes. And we saw that the highest peak amplitude values were seen for orbicularis oculi of all muscles when we took the average of those 8 muscles. And in another task, we saw also the highest peak amplitude for the OR muscles among those repeated audio signals. And that was when an unpleasant life event was told again, that is retold by the test leader. We also saw that the resting activity was significantly higher for the pain group, and that is the dark gray bars. And to the left, you see all 6 muscles together and a star that is significantly higher as compared to the healthy group, which is the light gray bar. And then if you take all the individual muscles, we saw the significantly higher levels for the pain group in the orbicularis oculi muscles, in the temporalis muscles. We saw a very strong tendency for the pectoralis muscles and also for rectus abdominis, abdominal muscle, and erector spine in the back. And during the startle, at the lower part on the left picture, you can see we measured the mean amplitude and during 200 milliseconds from the start of when we first saw activity rise in orbicularis oculi muscle, and we also took for the whole burst duration for each muscle. Now I will show you the results for that, and then we saw that the mean amplitude, you see to the left, the values for 200 milliseconds for orbicularis start was significantly higher for the pain group as compared to the healthy. And that was also seen for, we only looked at each activity burst and took all 6 muscles together and all 8 audio signals. Looking at the timing of the EMG, we saw that the duration, how long each activity period was, and then we call that the burst, that was longer for the pain group as compared to the healthy. And the latency was shorter for the pain group as compared to the healthy. That means that the activity came earlier. So the arrow at the top, you can see the latency from the thin blue line to the start of the orbicularis muscle is just shown here. And we made an index that when we look at all these muscles, if a person had all muscles activated, they should have a number called 1.0. And if no muscle was activated, it's 2.0. And as you say, the pain group had significantly lower values, but which means they have more activated muscles as compared to the healthy. And in the unpleasant life event, when it was retold by test leader, we saw that peak activity was higher for the pain group, almost the double as compared to the healthy, and also the mean EMG amplitude 200 milliseconds from the start of orbicularis activity. So in summary, you see at the top the title of our speech, and in the lower part, we saw that individuals with recurrent psychosomatic pain due to stress compared to healthy, we found this increased resting activity in the muscles, and the starter reaction was potentiated and triggered earlier, more easily, and more often. So, in conclusion, the children and adolescents with recurrent stress-triggered pain in the head and in the neck and in the abdomen has an increased muscle tension, muscle activity. This coincides with the pattern just I told you about the tender points, and also the studies show with pain localizations. And this start reflex has been used to indicate increased nervous sensibility due to stress in both animals and humans. And 93 just had his study showing that children with recurrent abdominal pain of non-organic origin showed these specific patches with tender points in the temporalis, trapezius, pectoralis, and rectus abdominis. And the same year, he also showed that, and that was for the first time, that simultaneous occurrence of abdominal, now it's pain, not tender point, pain, and headache and chest pain in these children. And possible mechanism, that is, the startle has been said to be triggered from nucleus reticulus pontis caudalis, and amygdala, that is a center of fear, and that is affected by stress, with Alvén showed already in 93, and it has a prominent role in the trigger of the startle due to fear here, amygdala. But in addition to these supraspinal projections, we also have peripheral mechanisms, and then we saw, we have put in our paper, we have published about that gamma motor activity can increase, and the muscle spinal input 1A and 2, and signals from other afferents 3 and 4 can increase, and that may contribute to the chronic muscle hypertonicity and pain. And here also stimulation of local chemonociceptors by various substances might contribute, such as bradykinin, prostaglandins, arachidone acid, potassium, and lactic acid. And also you have in chronic muscle pain, it has been shown that mental stressors can trigger long-lasting hypersensitivity of nociceptors in response to a subsequent exposure to a low concentration of inflammatory mediators. And the last picture here is that our hypothesis was true, that the start reflects in children and adolescents with stress-releasing recurrent pain is more easily triggered and gives a higher response than in healthy ones. And we saw this increased muscle activity at rest in children with pain, and the increased tension activity in various body muscles coincides with the pattern as with the tender points and pain localization, as just I've shown before in these children and adolescents. Thank you for the attention.
This is the third part, and I will talk about neurobiological mechanisms for psychosomatic recurrent headache and other pains. And this picture shows central areas for emotion and stress. And number one that you see in the lower part in the temporal region of the brain, that is the amygdala, the important center for stress. It's an almond-shaped and almond-large area of nuclear centers. And it influences and is influenced from higher brain areas, lower brain areas, and from the body in a reciprocal way. The next area I want to talk about, it's the insula. It's the green area in the middle of the brain. It's a center for perception, both from the body and from different areas in the brain. So their thoughts, epic memories, homeostasis, different stress reactions is gathered together And in the frontal part called the anterior insula, all these feelings become conscious. For instance, when we have a pain in the body somewhere, it will reach the anterior insula, and there you may recognize consciously the pain. In the next step, this information will go further to the yellow area. It's the cingulate cortex, the anterior cingulate cortex, and it's center for motivation, activity, and also stress. So when threats from different areas in the environment or from the body is reaching insula, it goes further to the cingulate cortex, and a stress reaction is created that will influence the brain and the body, and of course the center of stress, the amygdala, and the brainstem. And so there are many areas shown in this picture that is influenced by stress, both from amygdala directly and from the cingulate cortex. And of course, the body is just as important as the brain. And this picture shows the interoceptive nervous system that is of major importance for the body to inform the brain what is happening in the body. And it goes in the spinal cord via the brainstem and further up to the brain, different areas, including insula. And you will have a feedback between brain and body. So when stress elicits pain in the body, in the next step, the body will inform the brain about this pain. So it's important to have in mind that all these things are happening in the same time. This picture shows the insula in MRI studies. It's lightened in different situations. And in the middle, you will see the cingulate cortex that is also enlightened. The green area shown in the middle of influences the yellow area. And of interest is that the left and the right part of the brain may differ in their reactions and in priorities. And I will talk a little bit about that because that is of importance in stress. This is a picture from Craig, the big researcher and describer of the interoceptive system, insula, and what is happening in brain and body. And the two bars to the left is general reactions where both the left and right side of the brain is reacting in the insula and in the cingulate cortex. To the right, you see the second to the right. It's when the body in some way, the brain and body feels in some way threatened or increased activity. So you see that the right side of the insula will react and in pain, in threats, and the bar to the right, you see the left insula and cingulate cortex reacting in situations, listening to music, smiling, mother affection, and things like that. So we talked today about the bicameral brain, and on the left side, it's empathetic feelings, positive effects, calm behavior, oxytocin secretion, and nourishment. And the right side of the bicameral brain, it's sympathetic activity, negative effect, challenging behavior, cortisol production, and stress. So do we have any data that this is what's happening in the psychosomatic pain? Yes, we have. We have studied cortisol. And as you can see, in children with psychosomatic pain, the cortisol is increased compared to a control group, significantly increased. And the oxytocin is decreased in these patients. The blue bars to the left, that's the psychosomatic children. It's significantly lowered. The red bars is the control group. And then you have some green in the middle, that's organic recurrent pain patient. But it's the blue and the right you should look at. So what does this mean? It means, of course, you have increased cortisol and decreased oxytocin. That means it's the right part of the bicameral brain that is activated, especially in children with psychosomatic pain in stress. So in conclusion, cingulate cortex and amygdala are central areas in stress. That is well known today. And the startle reaction is potentiated in the children of psychosomatic pain. And their localization, as Eva showed you, are in the same as the tender point pattern and the recurrent pain. Children with psychosomatic pain have an increased oxytocin and an increased cortisol levels in serum. And that is telling us we have right brain dominance. And my last word is that when thinking of treatment of recurrent psychosomatic headache and other pains, it's important to stimulate the left brain, and that is with empathy, support, understanding, contact, deep breathing, and guidance. So thank you for your attention, and we will give two references that Eva and I and also Professor Sten Grillner has been working with. And the first is about the startle reflex presented here, and the second is a review of childhood pain. Highlights the role of negative stress. So thank you. Have a nice day.
So, yeah, thanks a lot for your presentation.
Yes, thank you, thank you. The jerky movements was not original. It was some problems with showing. Normally we Eva Andersson and I move more synchronized, so to say. But I understand no comments so far.
Yeah, so do we have any comments or any questions for Dr. Gostal Alfvin? I guess there are no questions.
No,
Yeah.
I guess so. Okay, thank you.
Thank you. So yeah, moving on to our last session for the webinar. It's from Dr. Lily Soda from Valus Foundation, USA. So yeah, Dr. Lily Soda, are you available? Yeah, perfect. Uh, Dr. Lily Soda, your voice is not audible. Please unmute it.
Hear me, right? Okay, I am here.
Yeah.
I found my first slide introducing myself, and I want to thank everyone for being here and participating in my talk and listening to the rest of the experts. I want to give them some recognition and appreciation for the information I've gained, even though I don't practice medicine, I'm not a brain person, but all this information as I was sitting waiting for my presentation has relevance to my work. As a school psychologist and a school counselor, we educate students at all levels, and we just have to look at their conditions, their abilities or disabilities, and the more we know, the more that we can plan for their individualized educational plan. You know, mandated is the American Disability Act in US, and I'm sure in the developed countries. So totally, this was a very informative, valuable hours that I spent this morning listening to Parkinson's, listening to stress related, the brain. Yes, all that stuff, so important. So thank you. And my presentation is going to take a little spin in the sense that it's going to be slanted a different way, but you will understand why I need to present this so we can share in a community of working with our students. First, let me just say that I am from National University. Wallace Foundation is one of the big bodies of the most current, the hottest educational practice to cure low achievement, and that was right even before social justice, stress, people feeling disenfranchised because of COVID. So this was supposed to be a cure-all practice to reach our students, reach our staff, working with students. And so you will understand a little bit more as I speak to it. Maybe some of you already know a little bit about SEL. Perhaps I can see a raise of hand or some comments if you know something about SEL, or is this new to you? Can I have a little response? You could just shout out, is this new to you? Have you heard of SEL? You know, what is it? I'd be happy to have you do a shout out, yes or no. All right, or if there's a way for you to respond to let me know. But the thing is, I am from National University. Like I mentioned, Wallace Foundation is one of the big bodies, and I will be telling you in my presentation who these big bodies are, what they are doing. I hope by the end of this presentation, you will have an idea, a good definition. What is the intent of this? How are we getting this across in our practices to accomplish this, and what are the needs that we have to make this happen? So if you could just bear with me, maybe 20 minutes, I can present this to you. So I don't know, I have not been able to assess your familiarity level. So if I am just giving you information you already know, I apologize. If I can give you some new information, I am ecstatic, because we want people, the more practitioners of different disciplines know what we do, because they are our collaborators. We need them to know conditions of our students, and we also need them to know how we practice to meet the needs of our students. So this is so fantastic. I'm so delighted to be here. All right, so I am from National University. Let me just start off with, this was in my abstract, the reason why we push for this, why this is important, why I want to present to you. Our society landscape, if you can kind of see, as you know, reading the papers, the media, I have the statistics of the bullets. I'm not going to bore you, but skim over quickly some of the statistics. But we know we have violence and crime at school. And the source from Principal's report is one of the ones I quoted, but we have other data quoted that is very relevant and evidence-based. So violence and crime at school, totally, if you look at the percentage of public school that is subjected to this, is 79%. That's over 50 percentile over the norm. So, and then if we look at numbers, it's like 1.4 million crime that is committed and students that are hurt, children that are hurt. You know, we moved to school shooting, at least 72 incidents of gunfire in schools in 2019. Even one is too many. All right, so just quickly some stats just to show you the intensity of the situation. Teen mental health, and the earlier presentation, we talk about stress, we talk about mental health for teens, and the bullying. I know you all know about the bullying statistics and where the school shooting come from, uncovered by a shooting, the student was bullied, and then the poverty. So these all have ramifications on behaviors of our students being emotionally unhealthy, all right? And so where we want to go, and I quoted two very famous people because I am from California. There are many that has kind of the same idea, but because I'm from California, some of my people that I really respect, Linda Darling Hammond, she writes lots of books. She was at Stanford as a professor. She does a lot of equity things where she talks about teaching circularly in a flat world, so pretty much evening out, leveling out the playing field. But now she's currently the president of the California State School Board, and her belief, and she is pushing for this practice that it could happen across schools, is to build classrooms with, you know what, I can't read the rest of it because somehow my I'm being covered, but if you could see it, I hope you guys are able to see it. But build schools with strong emotional support, and that supports social justice. So she's quoting this. And then David Gordon, been in the newspaper quite a bit in our area. He's the superintendent of Sacramento County Office of Education that covers every single county office in California. So he is saying to capture the minds of our students, we must capture their hearts. So this SEL, social emotional learning, is premising on this, and this is kind of the utopia they're reaching for. Okay, and then so how to define, and I don't know, Jessica, how I can shrink this or somehow, because I am not seeing all of my slides, but I know you guys could see it, or I may have just look at the little one and put my glasses on. But social emotional competency is for, I really cannot read this, but this tells you is a process of which individuals increase their pro-social skills to support positive, you know, this is so bad. Let me see how I can, is there a way I could shrink this? Let me see. Nope, if I could view it and zoom it down, maybe it would help. Let's see. Let me get it down to 66%. Okay, let me see. Nope, it goes the other way. It's even worse. Okay, let me see if I could do a bigger one. I don't know why. Let me see. I'm trying to. Is there a way to maybe zoom this, Jessica? No way. Let me try this. Oh, shoot. I just can't read my slides, and I didn't get a chance to print out a hard slide. Let's see if this works. There's no way to move this, huh? And let's, okay, maybe, but you know what? Is there a way to shrink this? Because now this blocks my, okay, this blocks, I could see it now, but it blocks. Okay, let me see if I could work like this. There's just no way to shrink this. Okay, so social emotional competency is the process for which individuals increase pro-social skills to support positive outcomes related to academics, relationships, and responsible decision making. Okay, so within the social emotional learning, there are some competencies we are going to teach our students. And once they learn this, they will be able to increase pro-social skills. And that will help them have positive outcomes, to do better in school, to have better relationships, and make responsible decision making. So just think about that. Wouldn't that be fantastic? Okay, so now I have to move this back, and then let me do this. Okay, sorry you guys. Is this my next one? Okay, so here are, okay, we did this quote. Okay, now let me show you this slide. Okay, and these are the competencies we're talking about. There are 5 key competencies. Being self-aware, being able to manage yourself, having social awareness, having relationship skills, and responsible decision making. And within these five competencies, we are hitting them in the classrooms. That's the first level of services delivery that we are going to try to accomplish in the classrooms, and then the schools. It is a school-wide practice, and having policies, meaning each district will have similar curriculum across the whole of the district. We educate a child beginning in the classroom, in the school, and having mandates within the school system, and then eventually branching it out to hit family and community partnerships and schools and communities. It gets bigger and bigger as they learn their competency. They expand further out. Okay, so let me go here, and then my next slide is and in the competencies is broken down, like I mentioned, the self-awareness, the self-management, the social awareness. Within the self-awareness, we're looking at these particular, it's kind of like a big funnel, the big idea, and then we start getting more and more specific and targeted. So we're talking about self-awareness. Within self-awareness, we're going to have subcomponents, right? So how to get to self-awareness, we must be able to identify emotions, have them be able to self-perceive themselves accurately. So they need to learn those skills. They need to recognize their strengths. They must have self-confidence, and they must have self-efficacy. So this is part of getting their self-awareness. If they accomplish this, that is a self-awareness competency. Then to self-manage oneself, how do we do that? Well, they learn how to control their impulses. They do stress management. So thank you for the previous presentation that segued me. The self-discipline, they must have self-discipline, maybe delayed gratification, long-range planning, they have to wait, self-motivation, goal setting, organizational skills, all right? And then the social awareness. First you have self-awareness, but now you have social awareness. This social awareness comes with being able to do perspective taking. Not only do we know about ourselves, we understand it, we know what we want, but be able to decenter ourselves, oneself, and hear the perspective of the other. This is negotiation stuff. And how do we work together? How do we collaborate? Having empathy, feeling for someone else, appreciating diversity. This is a social justice piece that's coming in, respect for others. All right, so that's the piece that encompass the social competency. And then the competency that continues are, actually they added one more. We haven't really talk about too much of it, but the research is happening with emotional intelligence. That will be the new competency. And some of you already is ahead of the game, just from what I'm saying. And with your work, you could already think about what would be emotional intelligence, what would make sense for emotional intelligence. I know you're there. Okay, but let's talk about relationship skills. So once I have the first 3 competencies, relationship skills are enabled. So in that, the communication, the social engagement, not being isolated, social engagement can include giving back to the community, joining organizations, being leaders. Just think of that, relationship building and teamwork, all right? How valuable is that? And then the responsible decision making has to do with being able to identify the problems. When I teach my students, and I tell them, working in the field, you must be able to identify a problem. You have to see the discrepancies. If you do not see the discrepancy, you do not see a problem to be solved. So you have to have a very scrutinous eye. All right, so analyzing the situation, and that has to come from previous skills of relationship skills, of knowing oneself, perspective taking. This is pretty higher order now. And the other competencies must come in play to get here. Solving a problem, of course, you're going to have to be able to talk and have teamwork, communication, evaluating, reflecting, ethical responsibility. This is what we want to teach the kids. We believe that this is just as important as learning how to read, how to write, how to do math. This is life skills. It helps them navigate the world. Okay, so this other one, next slide, talks about and what we have done in our university, in my university, in our School of Education. We have several other disciplines such as administration, and I mentioned school psychology is a department, school counseling is a department. We also have a higher education department, and we want to put this in higher education for the fact is we want to train teachers. We want to get the word out to all service providers that work with our students, because the more that the professionals and the service providers know about the value and what SEL does for students, the more it would be supported, the more we can get it out there. And thus, I am here, and I'm so happy that you have included me in this presentation. And with psychiatry and addiction, I mean, that just so totally wrap in, and also the disabilities that we've been talking about, students that have needs. So this is also valuable. So within the competence in higher education, we also want to encompass the administrators. The administration program is candidates who come in for their training to be principals, superintendents. So we need them because they make decisions. They are the ones that allocate money to us, coming from sources of the state or the government or grants. So they have to support us. They have to know what it is. They have to see the value of this. And academic program directors, yes, they're also decision makers. And we have to have faculty, the instructors part-time in the classroom, and the students, and then the student support services. These services need to be part of the knowledge base for SEL, making the decision, implementing it. All right. Okay. Let's see. Okay. I have a few more slides, and I'll go through them quickly. Don't want to keep you too long, but I just want for you to be exposed to some of the language if you haven't heard it. And if you need to do further research, or if you come across it, I just had a pop-up button, guys. I'm sorry. I tried to get rid of the pop-up button. And now let me see if I can find my way back. I don't know what's up with this technology here. If I close this off, I hope that I don't lose you guys. Let's see. I don't know if I could get rid of this. Somehow this pop-up button came out, and I don't know how to get back to you. Oh, shoots. Okay, I don't know what is wrong with this technology. Okay, I hope that if I do this X button, I don't lose you guys. Okay, perfect. Okay, I was so scared I would lose you guys and have to reboot. Okay, so this one talks about enhancing educational leaders' capacity to integrate skills, attitudes, and behaviors to deal effectively and ethically with daily tasks and challenges. So what this is meaning is within the education system, we have educational leaders, and we need the capacity to understand the importance of this and give us the support, adapt the attitude, have the behavior, not only to give us money, but also be able to talk the same language, walk the same talk as they interface with people within their discipline circle, the educational leader circle. So this really needs to get out there. And right now I'm getting it out to you guys, medical people, neurologists, the things that you guys do, the brain people. So hopefully this will have some impact. The framework will assist in nurturing interpersonal, intrapersonal, and cognitive competency, because it'll just come out of you to have an attitude, to behave a certain way towards students and our young children based on this knowledge. And it will be amongst the whole adult learning community. And these 5 competencies can be taught in many ways across a variety of settings and being practiced, model, behavior shaped by these 5 competencies. So if you are displaying it, you are modeling it for the students. You're giving them a template of how to do this. It's just common practice, like manners, you know, if you could kind of think of it in that term. So within higher education SEL roles, we talk about being a role model, being a leader on a team, having a collaboration, having leadership programs, having availability, transparency, accessibility, student support, and the compassion. Okay, and then when I presented this at our last conference, I wanted to get some input from the audience. So we had a panel, and I just want to share as I presented this, as we present and get the word out, we also want to gather like real-time things, what's happening in people's field that would be doable, that would make it work for them. So these were the suggestions from the panels regarding each of these competency. And the self-awareness, they're saying that maybe we need to slow down. We do live in a fast-paced society. We need to do reflections. We need to do journals. So they're adding how to practice the self-awareness. In self-management, they're looking at regulate, know their values, look at biases, hold themselves accountable, and breathe. Social awareness, praise others, build others up, empower them, have empathy, understand other people's viewpoints. All right. So this came from the audience in their participation. All right. So, and then other suggestions they have as to relationship skills, respond to feelings, conflict resolution, look at the wants, the don't wants, what can they give, communication skills. And responsible decision making is what is solicited from the group of participants. Know where you stand, examine your motive, be hopeful and find something good. Here's your problem identification, the real, the ideal, the barriers, the solution, the action plan. All right, as you can see, these are to help them achieve those 5 competencies that we talk about. All right, and I'm almost to the end. I got 2 more slides, and then this one is emotional learning, higher education, providing direction and support to our future leaders. So yes, the SEL needs to happen in the classroom, but most important is that we have to create it in the higher education, because we are the ones that are teaching candidates to go out and practice in the field. Thus, the role of our university. It has to happen in the classroom, but before that can be delivered in the classroom is our higher education to teach our future candidates the importance of this. So the presentation focused on the need for SEL in our higher education system, my university and other university. Embedding SEL into the coursework will provide adult learners the experience needed to produce the courage, safety, and confidence to shape their classrooms in an applicable SEL model of support for our PK-12 student. Yes, this concept is important, is valuable, it can make a difference, but we need to have it at a very higher tier level. All right. So with this is my last slide. The umbrella, then I'll give you some references if you would like to research it further. An umbrella, the SEL, under the umbrella is, remember the definition is the process through which individuals, we talk about students, we want them to increase pro-social skills to support positive outcomes related to academics, relationships, and responsible decision-making. So that can really make a difference in our underachievement, our high dropout rates, the stuff that I talked about earlier, the crime, the violence, the poverty, all that society landscape that we talk about. But with that, we must have the educators, the service provider, and the education system be aware, all right? And once their awareness, we also have to develop them so that they can have the courage to lead, to practice their own emotional self-care, so they have their attitude and their practice that just comes out of them seamlessly to provide that role modeling, that behavior, the manner that I'm talking about, extending that practice in professional community, all right? So I see the value of a school psychologist being able to work with the brain guy, the neurology guy. I mean, we do that a lot. We do assessment, we do screening, but we do need the neurologist to give us more and more targeted information. But within there is the conversation. Hey, do you know about SEL? And your student have this need. This is the collaboration. This is the ongoing conversation. And then implementing SEL. How does that happen in the classroom? How do we help our students achieve those competencies? So having SEL infused into the curriculum. And remember, we talk about from the classroom to the whole school, to the school district, to the family, to the surrounding societal organization, churches, maybe Boy Scouts, and then eventually the whole of the system. And then here are the 5 competencies again. The high quality social relationships and responses to life and responsible decision making is what is the utopia that we achieve for, that every child has this empathy towards each other, understanding themselves to make the good decision making, and being able to maximize all their abilities and skills, and then give back to society. This is the dream, right? Okay, so here are the references. And I mentioned earlier, Wallace is a very important foundation in terms of the research. Another one is Cassell, okay? And then in California, we have programs, and we have a philosophy. We have some specific programs written out. If I present next year in Paris, I'd like to open with this and really go further into what California is doing. But for today's agenda, I feel if I could just bring out the big picture for you, and there is such a thing as SEL. What is the definition? Why do we need it? How do we get it to happen at a level that could reach our students and make this happen for every student, the equity piece, and everybody being able to have this outcome of when they finish school, not only to be able to read and write, but also being able to have actually life skills. So, and again, I want to quote Linda Darling Hammond and Dave Gordon, which I started off with. You know, you have to reach the hearts of the students if you're going to educate them. And you could read Linda Darling Hammond's on your own. And so this is my reference, and I welcome any questions. And I know Jessica's going to ask for your questions, but okay, I'm done, and I'm the last presentation. Okay, all right.
Yeah. Thanks a
Okay.
lot, Dr. Lily. Yeah, do we have any questions?
Yes, I have got a question, and I
Yes.
would like to add something to Lily's presentations. Thank you very much for your presentation, Lily. I'm from Turkey. I'm Yasemin, and I'm studying with secondary school students about life skills. And especially I'm studying on the tobacco prevention programs. Because of that, I'm trying to use the refusal skills and life skills with the adolescents in my program. And I think that's an important point, locus of control for us, especially in self-awareness program. And I think we can improve this concept in the social emotional learning programs, because I can get very special feedbacks about this concept in my doctoral thesis dissertation. And there is one question for you. You mentioned about we can improve our students' social skills, but how we can do this in online process now, especially in COVID-19 process. I'm wondering, and I think you can add something about that. What kind of system do you use in your country?
Okay. What is your name?
Yasemin.
Yasemin. Thank you for asking that question. There's just no way to like give you a short answer, and I would love to dialogue with you, and I'm sure you could find my references. I've been to Turkey twice, and Istanbul. I love it. I saw all the regular tourists, and I love your culture. And of course, I don't know everything, but I have experienced your country, and I could talk to you about that too. I love it. But you asked me about COVID, so I just want to leave 2 points. One point is it is a hot topic. People do like it, and they use bits and pieces of it. But the problem is bits and pieces of it is not seamless. They could do so much more with collaboration and teaming. And that's the point of me being here. I know I cannot practice medicine, but when they tell me, like the throat doctor told me about the Parkinson's stuff, I'm just going, I have students, I will never be able to implement and practice this, but at least I know what the student's going for, what the student is going through. And this is how I could make some accommodations and adjustments for him. So SEL, going back to it, is kind of piecemeal. It's happening in a classroom. The teachers think they're doing a great job, which they are. They're probably even more motivated than a regular average teacher. These are motivated teachers looking for answers, and they go and look for strategies. But they're not supported. They do the best they can. But if they have a team, and if it spreads out to a whole school, how fantastic is that? A whole district, how fantastic is that? The whole world, how fantastic is that? Then everybody's on board, and they share the brains together, and you're not isolated. You share things with each other. And this is why I'm reaching out, and that's what at our university we want to train the candidates. And we do have modules. We have a philanthropist who has given us money. If you ever want to look up Sanford Inspire or Sanford Harmony School, there are models. But even though they're models and they're good, again, if we don't collaborate at the largest level possible, it is piecemeal. So that's one point I want to make. The other point is in this COVID, I have interns, counseling interns. It's amazing. When you relate to students, people at a certain level and empower them, you know, there are some, oh my God, the sky's falling, it's COVID, there's nothing we can do, we're just gonna be here. But when you say, hey, this is an opportunity for something new, you can solve a problem, you can be creative. And when I talk to my students like that, the work that comes out of their field work, it's just like breakthrough. And they're working so hard in creating templates, documents, even modules, lesson plans. And these are even things that they can use. Just think how powerful when you have absentee students or you have phobic students that don't want to come to school. So stuff that they're developing can be used to address those students that might have even like homeschool students if they have like, you know, injury. And so, you know, we have to continue to evolve our practices, and because they're responding to COVID, they're adding, you know, value to it. It is really amazing. But everything is virtual, everything is online, but all the stuff that they're adapting and creating can be used for specific students that I had just mentioned. And don't let COVID stop you. Make it help you create more stuff. Think outside the box. Yes, and I think practices needs that examination. Unfortunately, COVID costs us to do it, but it is creating some very innovative, good stuff too. All right. I hope that helps, but I told you it couldn't be a short answer. Yes. Okay.
Thank you. Thank you very much for your response, kind response. The other one is I would like to ask, you tried to show us a link about a site. I'm wondering what is it about exactly? While you are presenting this presentation, you tried to show a link to us. What
Yeah,
is that?
this has a link to everything we do. The SEL has a link to everything, you know, medical, you know, schools, family, social workers. SEL, because it's social and it's emotional, it has a link to everything. We have to come from the heart. And I keep quoting Dave Gordon, if we don't come from the heart, we can't educate. And we need teachers that come from the heart. And in our module at a university, we have a Inspire module that we teach teachers to be passionate and come from the heart. Because if they don't come from the heart, they can't teach the student to come from the heart.
Yes.
Uh-huh. That's
Yeah.
SEL, right? From the heart. Yes. And look at my umbrella. I think the umbrella is a really good breakdown, you know, from the idea to the next piece to the next piece to the next piece. And everything is so I mean, like we have so much subspecialty. That's kind of what it is. Once you get a category, then you break down that category into more variables. And then when you get those variables, you break the variables down even more. You get more and more minute, more and more targeted. Yes, it's crazy, huh? But thanks for asking those questions. I appreciate it. Uh-huh.
Thank you, Dr. Yasmin, and also Dr. Lily for your question and answer sessions. Yeah. So any other questions from that you have or any other comments you would like to make? Okay, I guess there are no questions or comments. So, Dr. Lily, I'm really sorry for keeping you wait until the
Oh, no
last program.
problem. I really enjoyed it. And then, Yasmin, I'm going to give you my university email. It's L, my last name, TSUDA, and it's at nu.edu. So you can email me, and I would love to hear more about your work.
Okay, I will give more information about your email from Jessica or you. I will try to find from the Google
No, it's okay. We'll share your details. Like we'll share Dr. Lily Suda's details to you, Dr. Yasmin. So don't worry.
Okay,
Okay,
thank
great.
Yeah.
All right. Thank
you.
you for your good job, Jessica.
Thanks a lot, Dr.
Thank
Lily.
you, Jessica, for your
So
contributions
thank
a
you,
lot.
Dr. Yasmin.
Yeah.
Yeah. So finally, I guess we have come to the end of our session today. And yeah, we'll definitely keep you updated about our future projects on this. And we really hope to see you all in a conference once the COVID
I hope I
situation
could come to
settles
Paris,
down.
but yeah, I'm scheduled for Australia. You
And
guys are
yeah,
right
we are
smack in the
having a
middle.
conference in Paris.
I know I want to go to Paris so bad. I have never been to Paris.
Mm-hmm.
And I don't know how maybe I could just go to Australia and fly into Paris for 2 days and go back to Australia. I don't know yet. I really want to be there and
Yeah,
present
so
California's addition to what I just presented. Yeah, because then you'll
yeah,
find
we're
resources
really
and
looking forward
modules.
for your presentation, like for your presence at the conference. So yeah, we really hope
Yes.
you come from Australia to Paris, and yeah,
Maybe
I'll be
I'll do
happy.
that. I don't know. I'll just see what my mood is because I don't let anything stop me if I want to do something. Okay.
That's
All
that's
right.
really great of you.
Okay.
So
All
yeah,
right.
thanks a lot for all of your presentations and all of your contributions, and also sharing all of your research works. And yeah, we really want to see, like in your email, please do let us know your suggestions so that maybe we can improve in our next webinars. So yeah, we look forward for your suggestions to us. Kindly do send us an email, and after the commencement of this webinar, we'll be sending you the certificates of your participation and everything. So you'll receive an email from us within next 20 minutes. You can just check the mails.
Okay. All right. Thank you.
Okay.
Bye bye now.
Thank you. Thanks a
Thank
lot.
you.
Bye
Bye bye.
bye. Bye.
This conference will now be recorded.